Good morning, everyone. The YouTube channel is open, which of course is the most important thing, so we're allowed to start. Welcome to the Cambridgeshire County Council Adults and Health Committee October 2024 meeting. I'm Richard Howitt, the chair. I start with the usual chair's introduction, which reminds us all that filming and photography are allowed in the meeting, and as is the use of social media, but not in a way that disrupts the meeting. And all of us, if we could make sure that our mobile phones are on silent or vibrate. We are indeed being live streamed, and a recording of this meeting appears or will appear on the County Council's website. It would make it a lot quicker if it appeared already, wouldn't it? But it won't. A couple of housekeeping points. When you want to speak, please raise your hand in the traditional way. And in accordance with the Constitution, before the end of 2 hours, I will adjourn the meeting for a short comfort break. No fire alarm test is scheduled for today. So if the alarm sounds, I will adjourn the meeting. We'll leave via the side doors over here to my left, and go down the fire escape next to the kitchen to the car park, which is indeed the assembly point. A couple of other points in introduction. This is the first meeting where we're not joined, sitting over there in that empty chair, by Will Patton, our head of commissioning. Will has decided to retire from the authority after a health issue earlier in this year. He, firstly, on behalf of us all, we wish him very well with his health. I am pleased to say that Councillor van der Ven and myself had a very good session with him last week to thank him directly on behalf of all the members' behalf. I would say personally, he's been one of our most valued officers during my time as chair. He's always been there with sage advice. He's dealt with difficult issues on our behalf, and the whole commissioning function is such an important one in what we do, and he has led that with great skill. And I'm sure many of the staff that work to him will miss him as well. So on behalf of the committee, I'd like to place on record our deep and warm thanks for a contribution over very many years of Will Patton, and to wish him well for the future. But I'd also, get ready to wave, I'd also like to welcome 2 interim appointments. People remember that Donna Glover has gone to be the Director of Social Services in Bromley, and so we have a vacancy in our post as Service Director Adults. And I'm very pleased that Sally Shaw, wave please at the back, that's Sally, has joined us. She started off as a nurse. Wonderful. She's worked all through the system, and she's also worked at a very senior level, both within the third sector and the Care Inspectorate in Scotland. And for the last years, she's been a senior advisor in social care at the Local Government Association. So she's bringing a brilliant amount of knowledge about the current issues and challenges to us. So Sally, thank you very much for coming to us, and we really, really look forward to working with you. And get ready to wave, Richard Hills. Richard is covering as interim for Will. He's coming to us as well with a huge amount of experience. He was part of the senior leadership team at Bristol City Council. He did all the transformation of their Discharge to Assess programme, and he's been Deputy Director of Adult Social Commissioning. He's obviously here as acting head of commissioning for us. At a personal level, I think you can't have too many Richards in running the show. So I welcome another Richard, and there will be more. There will be more. So don't hold your breath until we have a majority. But Richard, you're extremely welcome. Sally, you're extremely welcome. We look forward to working with you both. I did attend and Councillor Slatter, is she here at the moment? Yes. Councillor Slatter and myself attended the Health Watch Summit last week, which was brilliant. It was on health inequalities. And I just want to place on record once again how much we value the work of Health Watch. They gave some very, very interesting feedback around dealing with health inequalities that will come up, by the way, when we do a scrutiny session of the ICB on health inequalities later in the year. But I think both of us would want to say how much we enjoyed that day, and pass on our congratulations to Health Watch for another summit. And finally, you will find what I believe is a very light agenda. I don't want to start on a discordant note, but I think it is fair to say both Patrick and myself are frustrated that the rules which require us to deal with key decisions only as they're being interpreted are stopping strategic issues coming to the committee. We deal with them in spokes, as Councillor Bowden is not here today, will know, but we're not able to deal with them at committee under the rules. And I regard today's agenda as not dealing with the issues we should be dealing with, I have to say. And I could just keep that quiet and say that to Lucy quietly in private, but I don't believe it's good for this authority. I don't believe it's democratic, and I will put it on public record that that should change. And if you disagree with me, fine, tell me. If you agree with me, please, within your groups, and I look to the Conservative side as well as to those groups within the Joint Administration, to take this up, because the agenda that we've got before us today does not deal with the key issues that I believe the challenges for in our area of adults and public health. Any comments on my chair's introduction or questions? No. In which case, we move to apologies for absence. Rishenda.
Thank you, Chair. Apologies for absence have been received from Councillor Van der Ven, who is substituted by Councillor Nessinger, from Councillor Prentice, who is substituted by Councillor Goodliffe, from Councillor Taylor, who is substituted by Councillor Sanderson, from Councillor Bowden and Councillor Howe. Apologies too for this afternoon's health scrutiny session for Councillor Garvey.
And I've informally consulted people before the start of the committee, but formally, I've asked Councillor Nessinger to sit on my right in the absence of Councillor Van der Ven and to assist in the role that Susan normally plays in these meetings to support my work as chair. Can I just formally ask everyone if you're comfortable and happy with that? And I'm seeing nods all around the table. Thank you. And thank you very much to Councillor Nessinger. And it's quite good to have the leader of the council here listening to all of the discussions. So that's really great. Thank you. I now need to ask, does any member wish to declare any disclosable pecuniary interest or non-statutory disclosable interest? Councillor Daunton.
I'm never sure about this, so I'll declare it. I'm the country appointed governor on CPFT, and item 4 deals with relations with CPFT. So just put it out there.
My own feeling is that where one represents the authority on a body, then it's clearly not a conflict of interest, because your very role is to represent the authority. But if you or anyone else chooses to say it, to be absolutely transparent, again, no criticism of that. Anybody else want to say anything? No? Okay, thank you. That's all noted, and thank you very much to Councillor Daunton. Can I just check with Rishenda? I'm slightly struggling to hear. Is that my problem, or is it more general? It's me. Okay, right. Are people hearing okay? Yeah, okay. I'll listen very, very carefully, I promise. Right, we now move on to item 2, the minutes of meeting of 27th of June and of the action log. Firstly, on the minutes, are people happy to approve them as an accurate record? Yeah, I see yeses again all around the table. And this is the point where I sign them and pass them to Rishenda. Thank you. We now turn to the action log. An update has been circulated to committee members since the agenda was published. Yes, please.
Just on the minutes, can I make a contribution?
I apologise. I didn't announce matters arising. I'm sorry. I was wrong. Councillor Black.
Okay, thanks very much, Chair. I'd like to refer you to pages 13 and 14 of the agenda pack and the paragraph that goes from 13 to 14.
Sorry, I'm going to be advised about the procedure, so just hold horses for a minute.
Thank you, Chair. The minutes have been approved, so they aren't open for discussion.
So I'll allow you to speak on the action log and raise the point I'm sure you want to raise there. If I can announce that first, then you'll be able to speak, if that's okay. So I should announce that next, which is the action log, there's one piece I need to introduce to you, which is minute 169 about the second major trauma centre in Norwich for the region, which was part of our continuing watch in terms of what's been happening in health. And there's been no information about that we're able to find. I don't know if Val could just help me whether there's any further update on that. And Val is our acting director of public health, as you all know, but for the public, just want to say that. Val.
Thank you, Chair. Well, I think there's been stern attempts to get some response from the Norfolk and Norwich. I have spoken to a couple of people from Addenbrooke's and the ICB, and there is a kind of a greyness, but what I've gathered is that there will be a regional resource essentially around major trauma, one at Addenbrooke's and one at Norfolk and Norwich. And I think the question was, in terms of capacity, how many of Cambridge residents would go access Norfolk and Norwich? I think there are two things that will depend upon. One, in terms of the demand for ambulance services at that time, they will go wherever there's capacity in either area. And then secondly, in terms of specialisms, if, for instance, there was a neurological trauma, then they would go to Addenbrooke's because it's a specialist centre. So my understanding to date that that's the thinking, but I'm waiting for a person from NHSC to get back to me because I've been talking to various people trying to find out who is responsible or who would have the knowledge. But that, I think, probably makes sense in terms of the demand for services and the specialism.
Okay, thank you, by the way, for that. What I propose on that is that we've heard that and that the action is closed in the action log. But obviously, if new information comes forward that you'd wish to draw to our attention, there'll be no issue about that. Are members happy with that? Yes, they are. I see nods again. Councillor Black.
Thanks very much, Chair. Just to go back to page 14, we've got a thing there where...
Just to be absolutely procedurally correct, don't refer to a page number, refer to the question that you want to raise, if that's okay.
Okay. I'm just trying to help people work out what I'm talking about, but there's a piece of work that's being commissioned looking at opportunities for in-house services, and that the results and recommendations of that report are awaited. And I wonder if we could have an update on what's happened to that report and when we might expect it.
Patrick.
Yeah, thank you, Chair. So we've received the report. We as officers are going through the details of the report and working with the organisation that we commissioned. Our anticipation is that it was part of the business planning, so it's already built in. There's already a savings programme within the business planning. So that was approved at full council in February. And so our recommendations will form part of future decisions that we will bring through committee. And we will also share that with Spokes for further discussion.
Okay, I look forward to seeing it, Spokes. And I just remind the whole committee that what Patrick said at our previous meeting is that this will contain firm proposals for insourcing, which are practical and realistic. And we look forward to seeing those. Anybody else on the action log? Councillor, I will allow Councillor Black to come back.
I just wanted to make another point on the action log, and that is we've got the part of the action log. Can I say the page number to help? At the top is page 24.
You can say it if it's in the log, but not the minutes.
Right. Okay. Yeah, got it. And it says that the charging review would be added to the agenda plan for October, and I can't see that on the agenda plan anywhere. And I was just wondering what happened to it.
You get all the best words, Patrick.
Yeah, thank you, Chair. The charging.
Sorry, I didn't introduce you earlier, which is my error properly. We all know you, but for the public, Patrick Warren Hicks is the Executive Director of Adult Health.
Thank you, Chair. Thank you. So the charging review has concluded. We've got a paper which we're reviewing at the moment just to make sure it hits the original scope, and our expectation is that we will be bringing any recommendations for decision back to committee in December. That date slipped from the October one as promised.
And the only thing I'd add on that, Patrick has kept Councillor Van der Ven and myself up to date on this, is that to the degree it affects business planning, then officers should anticipate that to the best of their ability, of course, and so that we don't lose the opportunity to deal with any consequences from the charges review in this business planning cycle. And as members, I think we need to give them the flexibility to do that without prejudicing any decisions, of course. But I hope that carries the support of the committee. So, Councillor Seif.
Thank you, Chair. I'm looking at item 253. Well, probably that's the minutes actually, but it's page 5, and a subject I have raised previously, and I'm a bit surprised that it's not on the action log. And this is the Right Care, Right Person programme. We were going into I think we were told last time that phase 1 had been completed, and you were going into phase 2 and 3, which were being examined and would presumably be reported on about now, because it was set aside in early July to pick this up. I just wonder whether it should be on the action log, and whether we can have an update as to what is being done, and whether there are any financial implications, because we're going to be taking over some of the work that the police would have otherwise have been responsible for. Oh, sorry, I seem to have sparked something there.
It's not that you've sparked it, but I'm not sure we've got an immediate good answer. I'm looking to my left and right. Patrick, that does have it. Sorry, I misunderstood.
We might need to look to Rishenda around whether it should be on the action log or not, but in terms of an update, so phases 2 and 3 have been launched. We continue to observe that with the police and keep an active oversight of the activity arising. And we're pleased to say at the moment that actions haven't resulted in any additional pressures on our service. If there had been, there's a mechanism that we would report that back in and we would give an oversight. One of the actions which we have said is actually what are our services offer for people who are in crisis that find themselves in those situations actually further upstream. So there's a piece of work just to try and understand the more granular detail from the police, who are capturing a lot of the information and activity on there. But at the moment, most of the responsibility and response sits with both the NHS through the acute trusts and the Community Foundation Trust alongside of the police. But we and the district councils are also a key partner in that, because we may well see some of that knock on of where people aren't seeking services. But at the moment, we're pleased to say that we're not, to date, we haven't had any adverse responses to Right Care, Right Person.
Councillor Seif, are you happy with our answer, which will be minuted rather than it being added to the action log?
I am happy with that, obviously. I just wonder whether we could have a little bit more explanation as to what phase 2 and phase 3 actually was. What did it comprise? I mean,
I'm happy to take that as an action and share that with committee as a piece of work outside.
Okay, so we will add it to the action log. Are you happy with that, Rishenda? Yes. Do I see any other hands on the action log? We don't normally have such a full discussion of the action log, so we're all excited by that this morning. Thank you. So I just have to move to my next note, which says that the action log is to formally announce that the action log is noted. We now move to item 3, petitions and public questions. None have been received this month, so we'll move on to item 4. It is World Mental Health Awareness Day. So in Cambridgeshire, across the country, across Europe and across the world, people are thinking about mental health. And so what an apt opportunity it is for us to look at our own mental health services, and in particular item 4, mental health, section 74 agreement extension. We have Shauna Torrance, Head of Adult Social Care Commissioning, and Maddie Hill, Senior Commissioning Manager, who are coming to the table as we speak. Welcome, and thank you very much for being with her. And we've asked them to put this in the wider context of our aspirations around mental health, as well as the decision that we have today to on the actual contract. I think Shauna is going to start, please.
Thank you, Chair. Can everyone hear me okay? I've got the mic in the right place. As Councillor Howard just said, today Maddie will be presenting a recommendation relating to the mental health social work service. But before this takes place, we thought it important to set out to committee an overview of wider mental health support we offer across the county and the work we're taking place to improve this and manage demand. In line with the national picture, we know that there is a high level of poor mental health across Cambridgeshire, which has been exacerbated by the pandemic and cost of living crisis. The mental health social work service plays an important part in a much wider system aimed at supporting people with mental health challenges and diagnoses in a variety of ways, and with an emphasis placed on improving outcomes for the people who access that provision. With this in mind, we've been working closely with our local partners, including the NHS, district councils, independent and community sectors providers for some time now, to work out how, as a system, we can meet this growing demand and complexity in need. Sometimes this means ensuring that support for mental health is built into our well-established and existing services, with an example of this being links our commissioned housing-related support services make to existing mental health services while supporting people at risk of homelessness to maintain their accommodation, thereby avoiding the impacts that come as a result of their mental health challenges. However, there is also a need to expand provision, and Cambridgeshire has played a proactive role in this process from both an investment and a service development perspective. We are working collaboratively with the local integrated care system and accountable business units to review and reset pathways focused on better management of volume in demand and the needs that come through that pathway. This is being undertaken with particular focus on improving support for people in crisis linked to some of the discussion that's already happened today, ensuring better and more timely management of hospital discharge, and developing more consistent pathways into appropriate accommodation and housing options for people within Cambridgeshire. In addition to this, with increasing demand for mental health services in mind, and with the knowledge that people across Cambridgeshire do not always have equal access to preventative mental health support available across the county, the council this year made the decision to invest £500,000 within this area. This has enabled us to expand our community navigator service. This service seeks to empower people by giving them information, support, and techniques needed to proactively address immediate emotional and practical needs which can prevent an escalating mental health crisis. It has also enabled us to use the approach developed through the council's Care Together programme and working through our established Good Life service to develop seed funding opportunities which support the development of community-based projects that are co-produced with local people with lived experience, as well as local partners such as health, district councils, or housing partners. As well as this, it has allowed us to expand Good Mood cafes across the county, which have shown to achieve really good outcomes, expand our online counselling provision, and run further projects aimed at improving outcomes for unpaid carers with mental health challenges through raising awareness of existing and developing resources. Finally, underpinning all these areas of improvement and expansion is a desire to work closely with people with lived experience to do this, to ensure that any approach developed is relevant, outcome-based, and acknowledges their experience of what has and hasn't worked within services to date, and to continue to improve these areas with first-hand knowledge of their experience. And the Sun Network, our co-production partner within mental health, is key to helping us do this. The Mental Health Social Work Service, which is the focus of the recommendation today, forms a central part of the wider approach, ensuring that people assessed by these teams under the Care Act are guided to the right range of support to meet their specific needs and work towards better outcomes, some of which have been highlighted today. I'll now hand over to Maddie to give you a quick overview of the recommendation within the report.
Thanks, Shauna. So the purpose of the report is to request committee approve a 2-year extension to the Mental Health Social Work Section 75 agreement. As it sets out in the report, this service is currently delivered by Cambridgeshire Partnership NHS Foundation Trust or CPFT as we kind of refer to it, which means that our social workers are actually embedded as part of multidisciplinary teams, so including psychiatrists or community psychiatric nurses, and are managed in that way so that they can focus together on the person who needs the support and ensuring that it's joined up around that person's needs. The case study in the Appendix A kind of sets out a real life example of this, and I think the case talks about how the person accesses the district council and accommodation routes, and it really gives a flavour of what the service is about and how impactful and essential the social work role is in coordinating some of that. The section 3 of the report covers kind of the performance and generally just to say kind of it's in line with how the council performs in all of our social work areas. But we have a lot of ongoing monitoring and meetings and reports in place to ensure that that stays on track. The intention is to use the next 2 years to complete a review of the arrangements and also consider the options, some of which are set out in section 4 of the reports, about whether that is the best model for the council moving forward, and more importantly for people whose kind of lives are affected by this service. So in summary, the recommendation is to extend the existing Section 75 agreement for up to 2 years in blocks to ensure that we can maintain our statutory duties and the continuity of service while a review is completed.
Thank you to you both. Let's start with the discussion. Councillor Goodliffe.
Thank you, Chair. I understand the need for continuity of service, and obviously that makes sense. Thank you. Looking at section 3, particularly 3.6, obviously it highlights the routine audit from November 2023 and a deep dive nearly a year later. Can you tell us where this is up to, what the current findings of that deep dive and what changes have already been implemented in the service? And have we considered sector-led improvement partners and wider discussion to look at making sure we are doing the right thing, especially in view of 3.7 as well? Thank you.
I think we've got time, by the way, to take it in tranches today. So I'll take 2 or 3 together and then we'll have answers, but then I'll open it up again. Councillor Daunton.
Thank you. So I'm struck by the very short time frame between this paper coming here and the new system that you're requesting being put into place. I wondered why that was the time frame was so short. But my concern is really with the strategic review of future delivery. I'm assuming that this strategic review is concentrating on the management of delivery rather than the quality of care. And I'm assuming that we're content with the quality of care, that we're looking at the management framework or the structure around which that care is delivered. And I'd like some explanation of that, please, and some reassurance on that.
And last speaker in this round is Councillor Hay, please.
Thank you, Chair. I have a query about 2.5. It mentions that there are 3 adult social work teams, one for the north, one for the south, and one for Hunts and Fens. But when it comes to older people, there are only 2 older people social work teams, one for the north and one for the south. Does that mean to say we've got no older people in the Fens and Hunts?
If that was true, that would definitely be a headline from today. Again, I look to the bottom. I won't say who wants to start. Is it Shonefest?
Yeah, I'll cover these questions. So in terms of a deep dive, the findings that were identified were led to practice examples of where improvement could be made. So our quality and practice audit did a routine investigation as they would with any other social work team and found some recommendations and some needs to investigate further into some areas. So that deep dive has now been undertaken, and the work is being undertaken, the actions are being pursued alongside CPFT. So some of those actions will be linked into work we're doing with the wider social work teams in terms of ongoing improvement in practice and continuous learning and improvement. And some of those will be linked into some partners. So we're considering looking at the AMP service from an independent perspective and best practice, working in with some partners across the system and having some independent advice and some other areas potentially. But we can share the details of that audit, while I don't have that today, outside of committee in terms of the next steps and actions. But that gives you a high-level overview of what we're doing in the progress to date. So the deep dive has been undertaken, and then it is a set of actions that are being progressed proactively. In terms of the strategic review, absolutely, it's not focused on quality, as you can see, the outcomes of the service are in line with our expectations and the wider performance of social work. But what it does need to consider is whether the model that we currently have remains fit for purpose for both now and the future, and whether there's anything since the inception of that model that we can take and learn from, and what other options are out there available to us, and whether they could have an impact. So for instance, we are working towards a place-based approach, and there's a need to review the mental health social work through that lens and look at whether that service is delivering based on place, and ask that question of ourselves. There's also a joint element to that service across Cambridgeshire and Peterborough, and rightly so, we need to look at that joint management structure and whether we continue that. We continue on that line. But these are questions we're asking at this stage, the current performance of the service.
Could I just ask Patrick to come first to add to that, and then I'll bring you in, Councillor Daunton.
Thank you, Chair. So just two things. One, onto the first point, we have extended out to the question around peer support and peer challenge. So we have extended that out for peers. So the LGA and Department of Health work on a Partners in Care and Health. They're coming in to look at us specifically around mental health services, and in particular around the AMP provision. So we're kind of zooming in on the AMP provision, but more generally around mental health. So they're coming in to support that. I think the review that we're talking about, it will be about management, but ultimately will also be about quality of care, because there will be a question that we will ask, because they are interconnected really. So we'll need to be sure from the practice review that the quality of the care and the quality of our assessment process and our engagement with people is of the right standard, and then how you manage it is the kind of function, is the form that follows the function. So we will be looking at our management arrangements, but I think the review will also look at the quality of our care and the way that we support people, and hear from people about how well they're supported. So I think there is a twofold thing. So it won't just be around management. It isn't just about whether the function should stay within CPFT or be a standalone function, as some other councils have done. It will be around the quality of the care and the quality of work that we provide wherever that service may sit.
Councillor Daunton.
So I just want to be sure where CPFT fits into all of this. This review is being done in tandem with CPFT.
Absolutely. So CPFT are very aware of this paper. They're very aware of the recommendation, and we're working in partnership with them.
Okay, I wanted that to be put on record. Thank you.
It will be. Have you finished the answers to the first questions, or there's a bit more to go, I think?
There's one on the third questions in terms of the different makeup of the team. So that is how the teams have been established. But in the North and South team, they obviously cover all of the localities within that North and South. That is continually under review through how they manage demand, through waiting lists and all of the activity. We've given you an overview of the report. So if there is a particular issue and we feel that those teams are not able to meet that demand in that structure, we have a meeting on a monthly basis that will flag that very early, and we can look at it.
Any other members? Yes, Councillor Slatter.
Thank you, Chair. Yes, you mentioned more place-based approach, and as we know, our council likes health and everything. So the trouble is, we councillors pick up on things and try and make sure that we're putting things together. I'm community safety champion, as you may know, and I went along to the Cambridge CSP the other day, and that had a really interesting presentation on the A&E pathway for serious violence or injury as a result of violence, which of course in some cases, hopefully in minority, we're dealing with self-harm. In that one, it was the younger people they were concentrating on. You're nodding, and which hopefully means that you were not only aware of that, but were part of it. So I would like to know is how much you are able to resource these really useful local contacts. I mean, for example, in Fenland or East Cams, I hope that the community safety partnerships are doing similar things. It may mean duplication for county staff, but that local knowledge and local contacts with the voluntary organisations and support systems is key. So could you tell me how we're dealing with all 5 district councils in that way?
Any other members? I'll call myself then. 2 comments and 3 questions. Do we have another member? Yeah, Councillor Murphy before me, I think. Councillor Murphy.
Thank you very much. Yes, I'm really interested in sort of how robust this review process is, because this is, you know, yet another short contract, and short contracts are inherently, you know, not desirable for long-term partnership and so on. And so one hesitates to nod it through. Not that we ever nod things through, but and I'm really wanting to know that it's not just that it allows a review of some sort, but that the review is properly scoped. It's got all its quality measures defined and outputs sort of defined. It's properly informed by other activities that have been going on. It's planned. There's a time scale. There's you know, there's a piece of work there which is defined and is going to deliver in time to act then decisively for when the next contracting opportunity arises. You know, there's been talk about a review which could happen, or is a review of some sort is going to happen within the next 2 years. But, you know, it can't end when the contract comes to an end. It has to end sometime before that in practical terms. So there's a contracting process. I mean, this is a very high level report, and it could very well be that there is all this detail been thought through, but I'd just like some reassurance that's what's intended.
Okay, so my own contribution. Number 1 thing which I really liked in the presentation, and which is in the context of the fact that some hard questions being put at the moment about our relationship with the ICB and the health service locally and our ability to partner with them, which there's some difficult issues that we're teasing through that everyone's well aware of in relation to the Learning Disabilities Partnership. But in this field, as you've seen, although it's right that we have a review and that we have an open mind in that review, we're also expressing a vote of confidence here in the relationship that we have CPFT and the working relationships that exist between us. And that's welcome. It doesn't mean that when we see CPFT in December and scrutinise them, we won't ask very hard questions, because that's our job to do. But I would, listening very carefully to the presentation, I would just want to put that on record, because it does show that we can work very well with our health partners and them with us, where in many ways. And so I think it's good to put that on record as well. However, like Councillor Daunton, this is the 3rd extension of this contract, and we should have had this discussion 2 years ago, not today, and that review should have taken place already. And it's this failure to have a more strategic approach to our commissioning that we as members have been railing a bit against. And I've been discussing with Richard Hills already since he came to us, but we need to be more ahead of the game on this and not just extend and extend because we haven't got around to doing a review. And I'd rather just say that again, honestly and openly. My other comment, it's very good with the leader of the council here, but you know, there's every year a very tough budget discussion and very difficult to find priorities. But that extra £500,000 we put into mental health last year, I hope she, on behalf of us all, is proud of what we heard today about how that money's been spent. And we've been spending it, just to underline it, stopping people going into mental health crisis by getting to them beforehand, setting up local projects at the grassroots level with people that know what they're talking about, and having mood cafes, having more counselling, and directly expanding the help we provide to carers of people with mental health difficulties. And I'm proud of that. I hope you will be, and I hope every member of this committee will be, that was money well spent. And thank you to our officers for what you said about that, but also what you're doing about it. In relation to my questions, there's reference in the report to the new agreement with the police and ourselves and the health colleagues. And as we know, during the last year, the police have said they won't come out to some mental health crisis situations that they would do before. That's a national decision, not a Cambridgeshire decision, I want to quickly say. But I think it's right to ask our officers what's been the implications of that, what's been the outcome of that. Secondly, a year ago, we were talking about a big backlog on deprivation of liberty safeguards and a concern about that. I think there's good news on that, but I think it's important, as that's in the report, just to ask officers to just reassure us on what progress has been made on that, which is a critical area to make sure if the Mental Health Act is being used and people are being sectioned, that their rights are absolutely properly being respected. And it is no failure to assess and build in the right safeguards that is falling short. And then in the report, it says that there's been an audit by the Council Standards team with concern about the assessments that are being made. So notwithstanding what I said at the outset of this introduction, I do think we should ask officers a little more about what those concerns might be, even though I accept that you won't have all the answers today. But I do think it's fair to ask that as you've put that information before us, because obviously we should be concerned if the Council Standards team is finding that. Who would like to start off? Shauna.
Thank you. Just covering the link with the district councils and wider community sector. So we do this in a variety of ways. So through the Care Together programme, we very much have links within those areas, and that encompasses mental health and where there's a crossover of services. So part of the prevention offer that I referred to at the start has been done in collaboration with local groups and accounting for what they deliver, and then building around the gaps rather than duplicating when we're setting up that local provision. The teams also very much link with their local district councils because that will, as you can imagine, we'll have a variety of people that access services with Care Act eligible needs, but also have accommodation challenges that require district councils to support. So there's very much a kind of pathway link into there to help manage those needs.
May I come back on that? Yes. So the pathway that we were showed at the Cambridge CSP was really detailed, but clearly didn't have names on it. One would hope that that pathway applies to, I think that was just Addenbrooke's, I think, to other hospitals in our region. Hope, you know, if it's actually a template, fine, and maybe of interest to committee members, perhaps another time, if it is being rolled out all over.
Absolutely. There's Patrick. There's likely to be some variation between North and South, but the work I referred to as undertaken as part of the Accountable Business Unit and wider ICS approach is looking at the crisis pathway and the hospital discharge pathways and the needs within potentially the North and South, where they're looking at it from the perspective of the acute hospital. And so there will be piloting approaches happening, and there will be a review of what is going well and what isn't going well happening under those pieces of work at the moment. And the district councils form part of that integrated care system, as well as voluntary VCS partners.
Do you mind if I allow Shona to continue now, just to partly watching the clock?
Perfect, thank you. In terms of the review, there is, I'm pleased to say there is a plan behind that 1+1. The reason we've asked for a 1+1 is that the plan is to undertake the review within the first 9 months to a year. That will then give us a set of recommendations, and the +1 is to enable us to work with CPFT to deliver that and give us a good lead-in time if there are any significant changes that need to be made. There's a scope for that review at the moment, and we're looking at taking on additional resource and capacity to allow us to really drive at that and look at it objectively. Sorry, and then just moving on to your questions, Councillor Howard, we can provide an overview through Spokes or another forum around the deep dive and the key areas of lines of inquiry for the for the areas identified from a practice perspective. In terms of the impact of the national approach the police have taken, I think Patrick's comment at the start has probably outlined that at the moment. We've got mechanisms in place to continue to monitor that. We have monthly meetings in place where the social work teams will raise if it's having an impact on demand and there's or proving a particular risk in terms of level of need managed. But at this point in time, it is not being raised as a specific risk by the service. And then progress in terms of the mental health side of things. Maddie, you were going to pick that one up.
I think it was specifically about the Mental Health Act and potential changes in the future. Obviously, we, part of our role is to keep abreast of what's happening and tap into national and regional discussion groups and forums on that, and that will then inform some of our strategy. And if we need to change things through contract specifications or through discussion with practice.
We also have a practice lead embedded within our mental health social work team who is very involved in all of those developments and what is happening there. And she highlights to us where there's a need to accommodate any changes or amendments to the work we're doing. And that, again, gets brought through our monthly discussion forums as an item.
Have you completed the answers yet?
I think so, yeah.
Yeah, okay. Patrick, can you just add?
Yeah, thanks, Chair. So there were 2 bits, I think, just to add to Shauna's comments. Firstly is around police involvement and people in crisis, and I think that's addressed for Councillor Seif's response around right care, right person. The police are very clear, though, and they're not here to say, but the police are very clear that if there is a person with an identified crisis, they will respond to them. There are just certain aspects where they've responded and other partners could have responded, hence the title right care, right person. So, and I think the work that we've done on the 3 phases has identified other involvements of other parties to support people in the most effective way. So we will get a note back to people, but I think that's the response to the question about the police involvement in people in crisis. You asked a question around dolls. So for committee...
So deprivation of liberty safeguards, I know we know, but it's important for the public.
So for the public, deprivation of liberty safeguard does apply to some people who are also eligible under the Mental Health Act for support for their care and treatment. But people are sectioned under the Mental Health Act under a different legislation. It's the Mental Health Act, not the Mental Capacity Act, that drives why people are detained for their care and support. But in terms of dolls, we're pleased to say that the numbers have gone down. Kirsten just sent me a message. From 1,100 in September last year, we're now down to 800 in August, which for a county, most of the counties struggle with numbers. That's still not a place we want to be, but I think there's some really good work by the team to drive those numbers down. So that's around the deprivation of liberty. We've seen a positive movement in that backlog, but there is a distinct difference between people who are detained under the Mental Health Act and people who have a deprivation of liberty applied to them.
Thank you. I didn't hear an answer on the concerns that the audit had found.
That was the detail I agreed we would bring back outside of committee, Chair, with the overview.
Okay, I hear that. So I don't mean to press you to say something in public that I'm clearly hearing that you prefer to say in private, but I hope the public see that we're asking the questions And because, of course, if there are concerns, we should know about them. So thank you very much on that. Apologies to members to not come back again. I'm going to move the report recommendations that we're asked to approve the extension of the existing mental health social work section 75 agreement for 2 years on a 1+1 basis from the 1st of April 2025 at a total value of 1.25 million per annum, representing a 2.5 million for the total contract period, adjusted for future inflationary uplifts as part of the business planning process as established, and B, delegate authority for awarding and executing any subsequent extension periods to the Executive Director for Adults Health and Commissioning in consultation with the Chair and Vice Chair of the committee. Can I just see if there is consensus behind those reports? Nod at me if there is. I'm looking all around and that's unanimously agreed by consensus. Thank you very much to Shona and Mehdi. We now move to item 5, pages 41 to 50, the Drugs and Alcohol Treatment Services Additional Grant Funding. It's Val Thomas, Acting Director of Public Health, who will introduce this to us, please.
Thank you, Chair. The additional funding which this report refers to has arisen from the National 10-year Drug Strategy. And this funding was the first, covered the first 3 years of that strategy. It's a significant amount of additional funding. I think over the 3 years, it's about a quarter, but over the last year, it was about a third increase in the annual value. And it has had a significant effect in terms of service delivery, one in terms of getting people into treatment, so that unmet need, which is substantial. But I think probably there's also the added value in terms of addressing substance misuse. Is not just about the addiction, but the addiction needs to be treated alongside the wider complex needs in terms of the social need and housing and so forth. And we've seen a real impact as a result of this funding. The real risk is that we have no idea whether this funding will be continued after March 2025. And we've had various indicators over the past year. It's 1 minute it would be continued, the next minute it's not. And obviously this is in the context of the financial reviews being undertaken nationally at the moment. And what this paper explains is that we've taking actions in terms of risk assessments, put in place certain mitigations, because the risk is that people come into drug and alcohol services, they stay there on average around 5 to 6 years. It's a lengthy treatment, complex needs and so forth. And also we will start to lose those specialist staff. So this paper sets out those risks and would ask the committee to note the actions taken in terms of mitigating the risks. And also it's noted in the paper that and it's also in the FMR paper, that funding has been put aside to mitigate those immediate risks of staff loss and to ensuring that
FMR being Finance Monitoring Report.
Sorry?
Can we try and avoid
Finance
acronyms?
Monitoring Report, which obviously our finance colleague will be talking to. But that mentions that we have allocated some funding to at least mitigate some of the staff losses and we'll be able to maintain some of the care, but nowhere near to the extent that we would have if we had the full funding.
Thank you. And can I just say, in introducing the debate, my party is now the party in government, but I've asked for this to be on the agenda and for it to be part of a press release from the council, because I think it's important we speak up for local people, irrespective of our political affiliations. And I want to say that very openly, because I expect that to be a continuing part of how we need to go on, so that we're true to our mandate, which is to represent Cambridgeshire, and that we don't try and either advance or suppress issues that we should be raising on party political grounds. I now ask Councillor Seif to start the discussion.
Thank you, Chair. I've got a minor point, or possibly a minor point, and a substantive point. It may be that there's another version of the agenda out, or maybe I'm misreading something, but the recommendation seems to be just the proposed actions for mitigating the associated risk. Is that all there is? I think we're being asked for some money somewhere along the line, or transfer of reserve, but I don't see it in the recommendation. But
okay, so that's a really good question. Can I answer it straight away? Then I'll bring you back.
Yeah.
First of all, we've got an amendment. I didn't announce that we've got an amendment. Do I have to do that? Have I overlooked it? I should have done it first. Okay. I will let Councillor C finish though, because he's in mid-train. And secondly, just to underline, to stop any confusion, Val Thomas has already said that in the finance monitoring report, the financial action to mitigate the costs, the risks, let's say, is in that report as well as in this report, and the decision that we take financially is in that. So hopefully that helps clarify things in advance. Sorry, Councillor.
I didn't pick up the amendment, but understand that. My main point really is that this is a paper about treatment services, and clearly that's a very good thing. But there seems to be one word missing in this whole paper, which I would, and you're going to tell me I have, again, not read it clearly enough, but the word education. And I just wonder why we're not spending a little bit more money on that side of prevention. And I would quite like to see money put in to education from schools upwards, because if we can get people to understand what the risks to themselves and society and the damage they will cause to themselves, we might prevent and might reduce the need for the sorts of services that the treatment services provide. Maybe I'm being a little naive, but I think that education in the use or abuse of drugs and alcohol is probably the most critical thing that we could do as a council.
Thank you very much. So I have made a slight process error, for which I apologise to everyone. That's the first contribution to the general debate. I asked Val to make a note of that, and when we come back to responding to the general debate, if you can answer Councillor C's point at that point. I will now just introduce the amendment that's put forward by myself and Councillor Van der Ven, and I suspect Councillor Nessenga on behalf of Councillor Van der Ven, as long as everyone's nodding at me. Just checking with Shedder's nodding at me, yes. That amendment is commits Cambridgeshire County Council to make full representations in support of the Association of Directors of Public Health efforts to secure central government commitment to maintaining the additional drugs and alcohol funding. I suspect that's uncontroversial. In putting it, I simply say it's great that the Association of Directors of Public Health are doing this, but we should be actively doing it, not separately from them, of course, but in support of them, and be seen and heard on this in a way I perhaps already indicated, and so this would commit us to do it. Does anyone want to? I've got an established speakers list, but specifically on that amendment, does anyone want to comment? Nobody does, and therefore I can say, are we happy just to, by consensus, agree absorbing the amendment into the main set of recommendations? I'm looking at nods all around. We are, no objection. So, okay, thank you. So that's now incorporated in the main debate. We return now to the main debate, which is on the whole report. And we ask Councillor Nethsinger to come next, please.
Thank you. I think this is a really interesting and important paper. There are a couple of things I wanted to say on it. The first is how important it is that the paper indicates that the extra spending and the extra funding that's come through from central government has made a difference to the number of people we're supporting and the way in which we're supporting them, and the number of people who are managing to live independently and overcome their addictions, and the impact of that on wider society and the public purse is enormous. And I think it's really worth noting that this is that the benefits of enabling people to overcome addiction are vast, and they are large benefits to this council, because people are able to live independently and successfully in society, but they are also large benefits to the police, the fire service, health, and health in a big way, particularly, I mean, people with addiction issues are often very, very frequent users of accident and emergency services. So while I'm absolutely supportive of the work that we're doing in terms of working with directors of public health in trying to secure this funding, I think it would also be helpful to work with some of our partners outside. So my request really is that, and I don't think this needs any changes to the recommendations, but that in our work lobbying central government and our work looking at our risks, we also talk to our partners in health, in the police and in fire about how they can help us with that lobbying and potentially help us with mitigating the risks around this, whether or not this funding continues, because actually the consequences to them are just as great as they are for us. So I think it's a whole partnership thing. I'm not sure that was a question, but if not, I apologise. Thank you.
And I'm grateful if that point can be minuted, Rashenda. Councillor Daunton.
Thank you. Much of what I was going to say has already been covered by Councillor Nethsinger. I think that, I mean, it's a success story here, and it's important to celebrate that it's a success story. And behind the very real human stories, there's also a very powerful economic argument for maintaining the support, for maintaining the financial support. And I hope that we can make the powerful economic argument as well.
Thank you very much. Councillor Slatter.
Thank you. Much of what I was going to say has been said already, but it is another example of how what I was talking about earlier, the patient pathway in A&E, because although I agree with Jeff, we should be able to educate. On the other hand, the development of the adolescent brain, as we're increasingly finding from research, doesn't always allow for that. And the parental experiences, yet they don't listen to their mothers. So I think, I'm afraid it is in A&E that very often the crisis hits, and that's where the multi-agency interventions and pathways can help. And this scheme has clearly put in, as in 2.8, that the improvement in the quality and capacity of drug and alcohol treatment services. If we haven't got them there, the pathway is not worth the paper it's written on. We need to have the people who can then come in and rescue the young and the old from what the situation they're in as best they can. Yes, and the middle-aged, all right, yes. So yeah, and the chair need to have no fear that we're very happy to support him in lobbying the government. We won't hold it against him that it is his party in power. We know they've a lot on, but it is our job as county councillors of all parties to lobby the government on behalf of our residents. So don't fear, we will speak up.
Can I just say, as a father of young adult children who I hope and believe haven't got into drug and alcohol problems, they don't listen to their fathers any more than they don't listen to their mothers, in my experience. Councillor Murphy.
Thank you. Very much support what's been said so far. But in addition to, you know, it's not just the police, I would say it's the criminal justice system generally, all the sort of low-level offending that fuels the addiction, ties up courts and disproportionately populates prisons with short-term sentences and so on. So there's a kind of vicious cycle there. And really, and as when I was a magistrate, it was one of those things that was absolutely vital to be able to offer people who had reached a point where they were ready to take advantage of treatment. The worst cases of addiction are people who cannot resolve this on their own, and they need the specialist help, and they cannot do it without the specialist help, and they are often desperate for that help. So it absolutely makes sense for everybody, for the public purse, for the operation of the criminal justice system more generally, for everybody else, for those people's families, for those people themselves to live the sort of lives that they actually want to lead. this funding is vital for that, and so very much in support. It is a very, very sort of pervasive and costly financially and in every other way problem otherwise. So yes, very much support.
And my own contribution. So this is £2 million in what is a £7 million programme. So that's very substantial. We have 3,000 users of that service. We haven't invented those people. They're there today. It's a very high number. And we want to defend the services that we're providing to them for all the reasons that colleagues have said, and which I agree with. I think in the report, the fact that deaths from drugs are up because of the wave of synthetic opioids, we should note that. So there's an extra pressure, an extra crisis that we're seeing in our county with more people dying. And that's a really important spur for us all, that this money has specifically now allowed us to extend the service in an outreach way to specific hard to reach groups, specifically homeless people. And so people who are worried about homelessness and seeing people in the streets, this is the help we give. And so many of those people, drugs are at the heart of why they're on the streets anyway. And so the idea that we would have to cut back on that service, I don't think the public would have any anything other than support for us trying to do that. And I am particularly pleased, I know it will come in the finance monitoring report, but what officers are saying to us is that the rough sleepers service that we support in Cambridge in particular, homelessness isn't just a problem in Cambridge as a city. I'm quick to acknowledge, but it's a particular problem in Cambridge, and that we will not allow that service to close. So for residents, we give them that absolute assurance, assuming the recommendations go through today. And in response to what Councillor Murphy said, what our officers tell us is that we won't keep up with court referrals. We know there's pressure on the court system. We know prisoners are being released for reasons we all understand from the national media. And we won't be able to keep up with the numbers if we don't have this funding. And I think we have to be honest about that and to record our concern. I'll also just report on behalf of Councillor Van der Ven, I've discussed all of this with her in advance. She went and visited one of our Change Grow Live projects in Huntingdon recently, and she said to me that she thought the service was, quote, raw and necessary. And so I think on her behalf, I would just pass that on to the committee members. My one question to Vaughan from me, we know there's this problem that the figures only come out late because the national people have to announce it, not us locally. So we know that. Let's just park that. It's a systemic problem that we know about. But to the degree that you can answer that, in the report, there's a lot of issues about process. We're doing more treatments, we're doing more testing, right? But can you say something about outcomes without just burying us in figures? But can you say something about outcomes, along with all the other questions that have been put to you? Val?
Right, shall I start at the beginning of the questions? Right, I think, yes, the allocation of funding split between treatment and prevention is not ideal, certainly from a public health perspective and the long-term health outcomes of the population. We are obliged to provide treatment services, and we did push back when we received this additional grant funding. Well, you know, we have increasing rates of misuse of alcohol, particularly as this is of particular concern at the moment, but it's very strictly monitored on treatment outcomes. And there is quite a strict reporting schedule, and it doesn't really encompass prevention, this particular additional funding. At the moment, the funding we allocate to drug and treatment services, it's one of our most expensive pieces of commissioning. And I think prevention is picked up in other areas, certainly through our PSHE services. They have various frameworks that they work with schools. Also CASES, which is the treatment service provided by CPFT for substance misuse. They also go into schools as well. We are certainly looking at alcohol because I think in terms of prevention, that is where we are seeing pressures coming. And but I think it's something that we will be recommissioning this service for a new service to start in April 26. And I think then is the opportunity to look at how we get a better balance. But we still have this demand. We have 3,000 people in treatment, but their estimated demand, there's a further 6,000 out there. So you come back to this problem about prevention versus treatment, the pressing immediate need of treatment against the prevention, which is always kind of, well, let's manage the treatment. But it's not that nothing is being done, but much more could be done. I think a lot of work in terms of drug prevention, it then falls over into enforcement zone as well. And we do work with the police and community safety partnerships as well, but it's not at the level of investment that you see in treatment. In terms of Councillor Netzinger's question about partnerships, first I said about financial benefits. I think the paper does benefit, just to sort of say, I think the 2.4 billion is the estimated amount of savings that through an effective treatment centre. So, and that represents the full extent of services that it impacts upon.
That's a national figure,
That's a
presumably.
national figure, yeah. There's a whole sort of quality stuff around it and all that. And in terms of the partnerships, we have, I think 313 sort of just describes the work we've done with the Drug and Alcohol Delivery Board and the High Harms, and the High Harms group is represents everybody: criminal justice system, OPCC, police, and health. And also I brought it to the Population Health Management Board at the ICB as well, and we are going back there in November. They are concerned about the impact on A&E that this will have as well. And this initiative, which has arisen from Carol Black's report of, I think it's 2020 now, cuts across 6 government departments, and I think there have been representations to all our partners going up through those departments as well. So I think there is, we have worked very much with the system in terms of, and worked through the risk matrix with them as well, and identifying where they can help mitigate. And I think there is, it's called our clip edge, and I think there's very much aware that this clip edge is quite imminent and getting closer. I think the other question, thank you for all the people who supported it. I will say the members who supported it. And then something about the outcomes. And yes, we do have an issue with National Drug Treatment Monitoring System, which really limits to how much data we can share in the public domain. But I think we have seen, I think I have a lovely graph which I could sort of share non-publicly, which would show the numbers. And I think that's probably the most effective way of showing it rather than go into numbers here. But certainly we don't get the full impact because a person enters treatment services and they stay there for a number of years. So, but we are seeing that steady increase in people successfully exiting treatment services. And I can send you a nice graph.
And we've obviously discussed this outside the meeting. And that last point, there was a really key point with seeing people not dropping out, which is what that is obviously a risk, but actually successfully completing the treatment. We're seeing an upward graph on that. So thank you very much. I'm going to put the recommendations to the meeting, if I may. Which are, the recommendations are A, the amendment to commit Cambridgeshire County Council to make full representations in support of the Association of Directors of Public Health efforts to secure central government commitment to maintaining the additional drugs and alcohol funding. And B, we support the proposed actions for mitigating the associated risks. Again, can I look and see if I have nods all around the table? I am seeing that. No one's against, so I am going to declare that that's agreed by consensus. Thank you very much, and thank you very much to Val. Item 6, much earlier than usual, Justine, who sometimes doesn't get a good deal at these meetings, but today you are. Pages 61 to 90 is the Finance Monitoring Report, and Justine Hartley, Strategic Finance Manager, will introduce the report.
Thank you, Chair. And perhaps it's a good job I've got more time today because I think that perhaps there's more things that we might want to discuss.
Could you bring the microphone just slightly closer to your mouth, please?
So you have here the August Finance Monitoring Report for Adults Health and Commissioning. The position for the adults part of the directorate is that we're not expecting to spend the budget in full. We'll come on to that in a little bit when we talk about older people, because obviously whether you spend your budget in full or not is dependent on how much you put into the budget in the first place, and some of the trend data we'll have a look at in a minute. Public health also are forecasting an underspend at this stage of the year, although actions being looked into to see if we can spend more of that during the year. So it's a snapshot position as at the end of August, but hoping that we can push more of that out through the year. And you've also got the savings tracker and the reserves included in the report as usual. So just the three areas I wanted to draw your attention to. The first one is the older people's position. And you've got some graphs in the report that sort of show the trend data on both bed-based care and home-based care over the past few years. And what I'm trying to illustrate with these graphs, I think, is really how difficult it is to project forward on how much we're going to spend on those populations, those cohorts of service users. So what we were seeing pre-pandemic.
We're still struggling a bit to hear at this end of the table. Is
sorry,
you don't need to raise your voice too much, but just bring the microphone closer to your mouth. Pre-pandemic, we were seeing growth rates significantly above growth in the level of the older people population. And what we would tend to see is growth in the early months of the year, and then winter hits, and we tend to see either a levelling out or a reduction in our net service user numbers during that period. So that was what we were seeing pre-pandemic, and then you can see quite clearly from the charts that during the pandemic, as you would expect, numbers did very different things, and we didn't really see growth even across the 3-year period up to the end of 22-23 particularly. So 23-24, we started to see service user numbers really starting to grow again, and this is more marked on domiciliary care than it is on residential care. So residential care sort of followed the patterns that we'd previously seen, but domiciliary care just kept growing and growing and growing all the way through last year. As a result of that, we looked at our demand numbers for this year and thought, well, hang on a minute, if this is what we're starting to see, we need to reflect that forward in case that's what we continue to see. And obviously that's not what we're continuing to see. And I think that's part of my comment really about whether you spend more or less than your budget depends on how much you put into the budget, because with hindsight, looking back, often what we get with these packages is an element of backdating. So even when we're at the end of the year, we can't quite see the end of the year position. And you can see in both charts that our starting position in 24-25 is lower than we thought it was going to be. And that's part of what we're seeing here. So we are seeing service numbers coming through the door, particularly on domiciliary care, in line with the numbers that we were seeing last year. But we've got more packages ending. We're doing more work into that to try to understand that more. But at the moment, and through the first months of this year, the net numbers are below where we expected to be, and that's why you've got the position that you've got. So that was the first area I wanted to draw your attention to. The second is debt. Now, normally I bring to you an update from Audit and Accounts Committee. Audit and Accounts Committee this month is at the end of the month. So what I've brought to you is an update from Tom Kelly, the Director of Finance and Procurement, about the debt deep dive and the work that's in there. That's what's in sort of 3.1.6 onwards. And I've also brought you an update in terms of the health side. So you'll be aware we've talked before about the level of debt with health. We've had some really positive movements on that with health. We've had a first payment through already in October, and we're expecting significantly more to come in later in the month. So in terms of the overall debt deep dive, focus work continues, and I will bring you that update that goes to Audit and Accounts Committee to the next committee, the next Adults and Health Committee in December. But there is update there for now. We always knew it wasn't going to be a quick turnaround on debt, and to a certain extent, as revenue rises, you kind of expect debt to rise with it. So it's about kind of getting the overall picture. But certainly when you look back at some of the old stuff, you can see that there are some real inroads being made into the debt that we brought forward at the beginning of April this year. And then the third point you've just talked about in detail anyway on the drug and alcohol side.
just as a reminder, the delegations to this committee for the use of public health reserves have expired. We've used up the ones we had before. So it is a strategy, resources and performance committee decision, but you as a committee are being asked to endorse that recommendation to SRP, and then they will take that forward. So that will go through the SRP committee in due course. And in terms of the funding of that, we're looking at reserves this year. As you're aware, when we've got spare reserves, we bring them to committee to talk about how they might be used. We set aside a contingency for grant reductions on the public health grant. We saw this coming from quite a long way back. So we'd set aside 1% of the grant, which is 300,000. We've also got some uncommitted grant. And then I'm anticipating a little bit of the public health underspend in year to have that 400,000 set aside for those drug and alcohol services to continue. I don't really see that as much of a risk. As we say, we may not need them because the grants may be announced to continue. But if we do, then certainly we will have enough to meet that commitment. So that's all I was going to say, and happy to take questions.
Thank you very much. I'll make my own contribution later, but I do want to say at the outset that I know Justine and her finance colleagues, but also our older people's teams have been working really hard on doing the analysis that you described there. I'd want to commend you for that work and thank you. And I know it's continuing work because there's some profound questions being asked. And Kirsten, who doesn't just text Patrick with the answer to questions, but is sitting here and listening to us, is in the audience, smiling at that. But I genuinely thank you on behalf of the members, because this is really critical work. And I know that you're doing your absolute utmost to look at it. Right, let's have the questions and debate on the report. First of all, Councillor Seif.
Thank you, Chair. Thank you for bringing me in first, actually. This committee knows, because I've told them previously, that I'm some sort of an accountant. I'm an accountant, but not very much of one. In the past, when I've seen people present reports to me that show a significant underspend, I ask myself the question, what was the budgeting like in the first place? Is the accounting correct? Have it gone into the right, the costs gone into the right headings? And I suppose finally, whether, there's obviously an underlying reason, but whether some costs are being deferred. And one of the problems we have with any sort of accounting, including council accounting, is the annuality of it, that you have to report within 12-month period. Now, you've given, Justine, you've given us a very clear explanation as to why this year there is an underspend. But, you know, we're getting healthier as a nation, but death comes to everybody sooner or later. And we have longer periods of where we are in ill health before we die. And I just wonder whether we're taking too narrow a snapshot of these figures. It would be very helpful to me to know whether this is just a aberration in this particular year, you know, following the trends that you had before, or the trend has just been deferred, and, you know, 2 years' time, the people that you thought, or the numbers of people you thought were going to come into the domiciliary care or the home care categories will just be coming to us in future years. So I just, my question really is about the short-term nature of the report. I'm not criticizing, I'm sure it's accurate, and you've made the best budgetary estimates you can. But I just wonder whether we've got trouble in store in future years, and which we have to make provision for. So that's the essence of what I want to ask.
I'm going to take 2 or 3 speakers that I've got, and then I'll ask Patrick as well as Justine to come back. The next speaker I've got is Councillor Daunton.
Thank you. There was a report, I think it was 2 to 3 days ago, on national news, which said that the death rate, I'm sure other people saw it, the death rate in the last year was higher than normal. I think it was 4% up. So I don't know whether that's anything that's behind some of the figures that you're presenting. Another comment. I think I understand from what you said, Justine, that you're looking at the way that you're doing forecasting. Am I correct in that? And that you're maybe maybe the way that you're forecasting needs another look, and maybe I don't know if that's what you implied or said, and I just wonder if that needs some attention, the forecasting. I also wonder how easy or difficult it is for people who need our services to access them. And I think, I don't know whether that's obviously not your area of work, but maybe that's a question for Patrick, and whether some of this is to do with the ease or difficulty of accessing services.
Thank you. Councillor Nethsinger.
Thank you. Thank you very much for the report. And I also echo Richard's thanks for all the extremely detailed work that I know is going into the modelling of what the picture is actually looking like in older people's services and the numbers coming in. The point I wanted to make is about the kind of bigger picture across the council. And I think it's helpful for this committee and the public to look at what's going on in older people's in the context of also what's going on in other bits of the council, and in particular in children's services. So what we've got this year is a slightly lower number of people coming into to adults, older people's services, and a much higher number of people coming into children's services. And those are things that, I mean, in the context of the council's overall budget, actually the picture is pretty dire because the costs that are coming into children's services are really high, and it's sort of important for the public generally and the members of this committee to be mindful of the fact that we are a council, as are all upper tier councils, for whom it's very difficult to predict our costs because it depends on who turns up at the door, and we do our best every year. But since the pandemic, it's actually been really quite hard to predict those patterns because they've been quite different from what they were before. And upper tier councils across the whole country are trying to work out what's going on in this picture. But for this council, the picture is definitely that we have slightly fewer people coming into our older people's services and far higher numbers coming in for children's. And that is making the budget kind of difficult in places. So I just think it's important for the context of this debate, for the council, for this committee to be aware that while the picture here is looking probably slightly better than we might have expected in other parts of the council, it's really not. The other thing I wanted to pick up very briefly, and it's in the context of the recommendation to the Strategy and Resources Committee and the discussion that we've just had about the drug and alcohol service. It is a very good thing that you've been kind of looking far ahead for that and making sure that we have some provision in terms of the reserves. I think it's also worth making the point that reserves are something that can only be spent once, and the problem for us is that actually while they give us a little bit of security for that service for a year, it's not an ongoing solution, and that's why the conversations that we have with the new government and with our partners are so important. So thank you. Again, probably points rather than questions, but thank you.
Welcome part of the debate. Councillor Slatter.
Yes, my question follows on from Councillor Seif, actually, to do with the black arts of demography, and particularly the delayed undulations of home ownership. Now, there obviously was a generation that bought their own council homes, for example, and that has given them a financial cushion that may be delaying their need to come to the county council for social care support. I would imagine it's almost impossible to get that onto a graph, but presumably there are national figures coming through that actually show that we have got a bit of a time bomb of older people getting poorer as they run out of the savings that may have come with the value of the house which might have paid for the first few years in a residential home, and then the money runs out. It won't look like a very nice graph, but I just wonder if that's one of the things also that's making your life difficult to predict things.
Thank you. Councillor Hay, please.
Thank you, Chair. I'm just a bit concerned because looking through the report on the savings tracker, there's 44 lines on that savings tracker. And of those 44, 15 of them are black. That's over a third, meaning a third of them haven't even begun or we've got no data on. I'd just like some explanation why such a high number under black RAG rating.
Thank you. My own contribution. Let me deal with other issues than older persons first. On debt management, we look forward to that further report in December. But the very reason that we asked for the charges review is that we want to balance the efficient and effective collection of revenue, which obviously is important, with greater degree of sensitivity on anti-poverty measures. And we want those analysed together. So I hope in the further report that members' wishes to see both being addressed is important, not just in the charges review paper, but also in the report that comes to us under the finance monitoring report. Secondly, I also commend the fact that £17 million out of the £27 million outstanding from the health service has been paid, or is being paid, I think it's fair to say, and that has been of concern. And that I believe that work that has taken place behind the scenes involving the leader and the chief executive, as well as people around this table, that I think has been successful. And I just want to say that's a very good sign. It's not solved as a problem, but that's a very good sign that we're moving towards solving it. So I'm really pleased about that. I think the points about the reserves only being made once, it's a good warning to us all. But we'd be talking about closure in April unless something else happens. So I think, the fact that we are making this provision is really important to make sure the service doesn't collapse. And like Councillor Hay, I think there are important other things in this report, including the savings tracker report. But both Councillor van der Ven and myself take a very close interest in the Care Together programme and the work supporting the establishment of local micro enterprises to support social care, neighbourhood and village level. And it may well be that the savings are in the black box, to take Councillor Hayes' terminology, but we think that this is incredibly successful, and whether and how far it produces savings and how quickly is a completely proper question, and we'll hear what Justine has to say in a moment. But this has been an incredibly successful part of what this administration has done in terms of trying to make the care services more localised, more responsive, create employment, create consistent quality of care, tilt the balance away from large, big companies towards locally based ones. And so although it may well be that some of the savings that were part of the aims of this programme haven't been realised, we wouldn't want that to be understood as anything other than part of the picture. And the whole picture is that we are very keen and supportive of the work that is being done on this. Which brings me to older persons. As I've said to Councillor Bowden, he's obviously absent today, has apologised, but this is the big picture issue that we really should be addressing. It's gone up since our last meeting. I do commend what our officers are doing in trying to understand it. I think what Councillor Nessinger has said to us is fair, because it's part of the reality that is confronting us as an authority, so I don't criticise or blame her for saying that. But it's the role of this committee to make sure that that older people are served. And I worry, like Councillor Daunton, that there's unmet need and there are barriers in the way that we're providing help. That means the need is out there, but we are not picking it up. Age UK has some very clear research talking about very deep levels of unmet need in our county. So I think there's some evidence which suggests that, but that's the evidence that at the moment officers are searching for. What gives me great confidence and Patrick will speak for himself in a moment, is that our officers are asking those questions as hard as we are themselves, if not harder. And so I believe that a proper recognition of the needs of elderly people is part of the wider picture that Councillor Nessinger is talking about. You know, it may well be that it's in greater numbers of deaths and that we're seeing that. And these are really difficult issues, members and members of the public watching. And what I want the members of the public to know is that when we're looking at this, we're not looking at it in terms of statistics, not looking at it just in terms of finance. We are looking at it in terms of people in need, people who have family members who are concerned and are watching what we're doing, and that we are absolutely doing our utmost to ensure that the duty that we have to those people is being fully upheld by this authority. And I'm sure Patrick will add to that in his own contribution. Justine.
Thank you. Okay, so starting with the first question about, is budget setting correct? Correct. It's always a best estimate. It always is. All of our forecasting, all of our budget setting is always a best estimate based on the data that we have at that point in time of where we're going to be. It was the best estimate based, you know, on what data we had at the time when we built the budget for this year. But obviously, looking at what I was trying to demonstrate, I think, with those graphs really was how the trend data has shifted so much that actually when we look back at it now with hindsight, and we can see that we started below where we expected to be, it sort of shifts that picture. More and more data comes in, the picture constantly keeps changing. So there isn't really a right budget and a wrong budget as such. It's our best estimate of what we can put in. And so in terms of forecasting, I wouldn't say we're looking at doing forecasting differently, because our forecasting is very, very complicated. We do a huge amount of work with the service because it's so complicated, but you know, we're looking at the numbers of people we've got in the system, the numbers of people we expect to be added onto the system, the numbers of people who are approaching the threshold in terms of their care, who then might come from being self-funders into the council paying for them. We're looking at income, we're looking at the backlog of financial assessments, there are loads and loads of things. It's a huge amount of work that my team do with Kirsten and her team every month to forecast the position that we're going to be in. But all I can say is every number that you see will be a best estimate of where we're going to be. There's nothing in there, Councillor Seif, in terms of your questions about costs being deferred. We're continuing to do it in the normal way, and we're constantly trying to refine that forecasting and look at other things and think about new things. So it's a constant exploration process, but it is always a best estimate. I'll let Patrick do the how difficult is it for people to access services question, if that's all right with you, Patrick. Coming on to Councillor Nessinger's comments, I completely agree with all of that. And even within adults, yes, older people's underspending, but we've got pressure on mental health, we've got pressure on learning disabilities. So that is that constant in all of those cases. We've got best forecasts of where we're going to be, but we'll never get it spot on in terms of the budget. We're always just trying to get as close as we possibly can. Councillor Slatter, home ownership. I'll go and have a look actually about what data there is about older people getting poorer and see what, certainly we hear that from some other councils sometimes, but I'll look into that going forwards. And then Councillor Hay, I think, was the last question about the savings with the black rag ratings. So I think it was a challenging set of targets that were set, the savings targets for adults this year. The ones that are black generally are streams of work based around big pieces of diagnostic work that need to be undertaken. And most of those are in progress, but we haven't got the outcomes for it. So they're black for this year, but the expectation is they will deliver for the future years. So I guess we're being slightly cautious in here and showing them as black because we don't exactly know how we're going to deliver them, but the work is underway to make sure that we're in a position to deliver those for the future.
Councillor Hay, you're right to keep us on our toes. I think it's a completely proper question. Patrick.
Yeah, thanks, Chair. So just on the work that Justine touched around the modelling, so there's a huge amount of work, as Justine said, and it's very much a team together that we work through those kind of understanding and modelling. I suppose the questions that are coming out at the moment, because the activity isn't following the actual, are some of the questions that you suggested in your question around. So where are those people? How are they being accounted for? Are we capturing them elsewhere? Are they on a waiting list somewhere? And once we're clear on that and we feel more assured together on that position, and if we are in this place, then I think further questions need to be asked about, so why have we moved so much away from where our forecasts were? What's been the underlying action? So we know, for example, particularly around domiciliary care, that we're starting to, people's care packages, more people's care packages are ending than we expected to. So questions would be, why is that? Val's team within public health have done some work with us around the overall across Cambridgeshire around death rates and the position on that. But actually, is there something more granular that we need to understand about? COVID had a lot of things, challenging aspects of it. And one of those is the historical data that we've often relied on has been so different since the end of the pandemic, or since the pandemic period. And so that's been a real challenge for us to understand the flows and the demand and the way that that's affected. We also are part of a wider Eastern Region network for adult social services. And so I speak to other directors about their activity and their performance, and they're under significant pressure in their older adults. They're under significant pressures from greater numbers coming out of hospital, greater numbers already in service, greater numbers in bed-based. So again, we're trying to understand more about neighbouring councils and the factors that are influencing them, and testing that against our assumptions to make sure that it's it's not an exact science, but we're doing as much work as we can with the information we've got available to both understand our current position and to also inform future projections. So that's on the modelling bit. In terms of ease of access, so our activity of people coming into service is as previous. So if you looked at our forecast and our current activity, it's no different. So we're not seeing fewer people coming into service. What we're seeing is different behaviours once they're contacting the council. So we aren't seeing a different change in numbers. What we're not clear about is the pathways that those people go on once they've been into service. So we aren't seeing that in terms of access. And actually, if you look at our performance as a council against regional comparators, then we see more people from communities coming into our first contact. So our numbers of contact are greater than other councils, which is another question about our early intervention offer, because we're seeing a greater number of people presenting at the council rather than other councils which have got a stronger early intervention model that helps people find their own way and support themselves and not presenting. So we see a higher number of people presenting. It's the activity within that we're trying to do the deep dive on. So got that one, did that one. Older people getting poorer. In fact, that's been a question that I was asked earlier this week, which was around the position of self-funders, and actually the numbers of people who we have who are capital rich but cash poor. And so we are doing some further work. Kirsten's doing some further work on understanding that makeup of the population who have got properties but maybe not entitled to benefits. So they're living on, potentially just living on pension with maybe some support, and but have a large property that's got capital value but doesn't have any income for them. So we are doing that piece, and we wanted to also understand in terms of our activity. And actually, this was a question we were asked by Councillor Nessinger, which was, we need to look at other councils neighbouring that have a similar makeup around their population, to whether or not self-funders are actually influencing some of our demographics and some of our change in position because of the self-funder market, and how are we forecasting that self-funder market potentially in the future coming through our door. We have a team that deals with people whose capital drops into a place where they need extra support. But we just need to look forward on that numbers just to see whether or not we've got our projections right on that basis. And then in terms of the black and the savings, I think Justine's probably covered it all, but just to assure you, there are, as I say, there are some key large themes in there, and these are work streams within it, but work is already underway. So the in-house review is in there. We've done a piece of work on that. We're just assessing a piece of work on the diagnostic to help us understand that. And the LDP is in there, and committee is aware of the some of the work that we're doing with the ICB around the decoupling of the LDP. So they form part of that.
Another acronym, Learning Disability
Oh,
Partnership.
sorry, Learning Disability Partnership, apologies. And then, but what I would say is, even though they are black and it's the way that we report that they are black, we are still doing work in the background. We're not just waiting for the diagnostic, we're also seeing other aspects of our work to see where we could drive further savings out of those particular projects.
I can't think of the reason why you're being asked to do more work on older people in poverty, but maybe people who follow the council will learn more in days to come. The recommendations that we have are: A, we note the Adults and Health Commissioning Finance Monitoring Report as at the end of August 2024, and B, endorse the use of up to 400k of public health reserves to support the mitigation of risks if drug and alcohol grants end in March 2025, subject to the agreement of our friends, close friends in the Strategy, Resources and Performance Committee, especially when we want money. Are people happy with those recommendations? I'm seeing nods. Anyone against? That's agreed by consensus. We're over halfway, so I announce a 10-minute comfort break and we'll resume at 5 to 12, please. take your seats, please, ladies and gentlemen.
Bohemia is affecting.
All right, we now welcome back to the Adults and Health Committee October 2024 meeting here in Cambridgeshire. We now, after the adjournment, move to item 7, the Adults Performance Monitoring Report, Q1, pages 91 to 110 of your agenda pack. And I'm really pleased that, just like Justine in the previous paper to Sarah, we can do the really justice to your paper this month. We're not having to deal with it in an overrushed way as we often have been. And so I'm delighted to introduce to you Sarah By, Head of Performance and Strategic Development.
Thank you, Chair. Good afternoon, committee. The report I'm presenting today is the Q1 performance report for 24-25 and contains an update for April to June. 3.1 in the report contains a summary of the key areas of performance for that quarter. Some particular areas to note in the report are areas of improvement around our safeguarding indicators, which all 3 of the indicators which are included in our performance report have improved for this quarter. And also our reablement services continue to support people to maintain their independence, and reablement continues to perform exceptionally well compared to sort of national and regional comparators. We're also, in terms of our self-directed support programme, looking to improve our direct payment offer. That continues, and we've got a number of initiatives within that programme that will support an improvement to that indicator. It's one where we know Cambridgeshire doesn't perform particularly well, but we've looked at rescoping the programme, a focus on sort of training, culture and practice to make sure that we're offering people with support needs the chance to have a direct payment and making that as easy as possible for people. There's a summary contained at the top of the report and then a more detailed appendix with indicators and all of the performance measures against those. So happy to take any questions from committee.
Members, Councillor Hay.
It's not so much a question, more of an observation. I found it very confusing on indicator 230. It says the current quarter is 1188.6, previous quarter 4319.5. Surely that's a year's figure and not a quarter's figure.
Do you want to come back straight away on that, because that's just an interpretation question?
So the information that's contained there is the number or the rate per 100,000 of population. So it's not an actual count of people, but it's a rate per 100,000. So that allows us to compare that against other populations in other councils where the population size will be different. So it's a rate rather than an actual count.
It's confusing because it says previous quarter.
Patrick.
Thanks, Chair. Just to say, so this is Q1 that we're reporting on. So the previous quarter was Q4. So it's for last year and it's cumulative. So it will be higher. It's just the way that it's presented. It describes it as previous quarter, but actually it's the final quarter of the previous year. So we might need to think about how we visually present this so that it isn't misleading. It looks like your quarter's dropped, but it's because the Q4 is the last quarter that's reported, which shows a higher figure. It's just presentationally not very clear for you. Hopefully that answers it.
Councillor, you get the Eagle Eyes of the Day award for the second time.
It just says it's declining, and on quarter figures, it didn't.
No, you spotted it very well. Is there anything else that you'd like to add in your intervention, or that's it, is it? Yeah, thanks. Who else have I got? Councillor Murphy.
Yes, thank you for raising that. Is that, would it be accurate to say it's the position as at Q4 rather than it is the previous,
yeah, I think
previous quarter? I think that's what's confusing.
Yeah, it's a really helpful observation, Councillor Hay, and I think we just take it away because because previous quarter and change in performance, we just need to make sure that they're the correct descriptions and definitions of a declining against a previous quarter, which is potentially a cumulative number. So we will take it away as an action.
Contribution from me. First of all, reablement is a huge success story. I completely agree with what Sarah says. And we should say it, you know, this is a direct service to the council, not a contracted one. And they're people that go in and would put in the extra grab rails and raised toilet seats, and actually are helping keep people in their homes by doing it. And they're doing much better than the equivalent teams elsewhere in the country. And we should be proud of them, and we should send our thanks to them because it's not a sexy service that people think about, but it's absolutely a brilliant service that makes a huge difference to people's quality of life. On direct payments, I think Sarah says what you can say today, but the officers understand we've been saying for 3.5 years improve direct payments and been assured it's happening, and it hasn't. And so those efforts really must work this time. Okay, we're fed up of hearing those assurances. There's no discourtesy intended by saying that, but what was a priority for this administration has not happened and should. On the prevention being successful because we have a high number of contacts, low numbers actually having to go into permanent provision, I think Patrick's already referred to that in the earlier debate. You know, perhaps the high number of contacts is also an issue because we're not doing enough preventative work out in the community. So just let's link those two comments together. But I think it is a proper question to put, is the fact that we have high number of contacts and low numbers of provision because we're not very helpful to people and we're turning them away? I'm sure it isn't, but that is what the public, I think, would expect us to ask, to make sure that we're not simply having the lower numbers because we're not accepting that people are eligible when they should be. And so it's a fair question, I think, for us to ask. I welcome the fact that although there's been a big improvement in the timetable for assessments, there is recognition from officers it's still too high. And that's exactly the sort of honest, open discussion we need as members and at this committee in front of the public. And I commend you for recognising that and recognising that we've done really well to drive it down, but we need to do better again. And finally, you report the 2,000 carer conversations, which obviously we welcome. But people will remember that when we reviewed the carer strategy, what we learned is that we were very good at giving assessments to carers, but not really listening to what they said. So we got the numbers up, but we weren't doing very well actually in terms of the quality of the service. And again, I commend the officers for being very honest with us at that time. But I think it's important in this report that we don't just see the numbers of carer conversations, but that we're seeing whether the quality of those conversations, whether we really listen and act to what carers are saying to us, that we're improving on that as well. So I ask Sarah that question. Any other members? Councillor Slatter.
Thank you, Chair. Just back on that last point about the direct payments, have I missed, is there a figure for the number of people who have been on direct payments and then come off them? Because one can think quickly of some of the reasons why this happens, a crisis, the carer agency goes down or whatever. I would be interested to know how much that happens, and if it sort of people feel their fingers are burnt or they no longer feel they can cope with direct payments, because I can see it being quite daunting for people not to have the safety net of the county council. Thank you.
I'm not seeing any other member hands. I am now Councillor Daunton.
It's really a sort of general question where these indicators come from, whether they're national indicators or local indicators. And I've got one particular question in relation to indicator 235, total people accessing long-term support in the community aged 65 and over. What's the magic of the age 65? Why aged 65?
There's smiles all around the table from people either coming up to the age of 65 or just past it. So there are many philosophical ways we could answer that question, but I think Councillor Daunton means it in a social work sense. There's a very serious point to it, and I don't mean to detract from that by introducing a little bit of levity to our proceedings. I don't see other members' hands. I see Kirsten Clark has come to the table as well, and she's very welcome. Sarah or Kirsten, whichever of you wishes to come first.
Thank you, Chair. I'll take a couple of the comments that you've made, absolutely linking some of the debate earlier around the number of contacts that we're getting, and it's part of the work that we're doing to understand that flow and demand where people are contacting the council, what happens. But we've got some very effective early intervention services, so adult early help and our tech offer. So it may be that people are getting what they need, they're just not needing a full care and support plan and an assessment. So but we are tracking all of that through. In terms of direct payments, we are starting to look at the reasons why people are ending a direct payment and the reasons for that. It is a small number of people, but it's part of what we're looking at for our Care Quality Commission assurance visit. So we'd be able to have a look at those reasons and perhaps include those in a future report to give you some assurance there. Kirsten's going to pick up on the rest of the point around direct payments.
So in terms of the reasons we're seeing operationally, so like Sarah says, it's small numbers, but I recently looked at the last 5 packages that were closed through direct payments to understand that further. And they were large packages of support, typically with younger people, not over 65. And actually it was the stress of not knowing if the PA is going to turn up, or when the PA is poorly, what's going to happen. So it was around those issues, which is very different when you work with a provider who could deploy different staff in. So obviously we're looking and working with commissioning in terms of individual service funds. How can we move then this form of self-directed support to an alternative support that could still meet people's outcomes in a different way, rather than going back to kind of traditional support services? So just to reassure you, we're picking that up.
I'm glad you've said exactly the thing that I'm thinking of. And I think that is part of the reasons that word gets round and people might not come on to direct payment. So if we can crack that one, then we probably will improve our figures. Thank you.
I'm not seeing other hands around the table. The only thing I would add on direct payments is that other authorities are doing better than us. And so it's not about the capacity or the willingness or the vulnerabilities of people taking it on. We are underperforming, and you know, I want to say that we are utterly committed to trying to change that. I think Patrick does want to say something.
We are committed to doing that, but there are some interesting approaches by other councils on how they get their direct payment numbers up, and that's not what we want to do. We want to really fundamentally address the way that people feel more in control and make those decisions. There are other ways that you could do it. So you could basically stop everybody's commission care and give them all a direct payment to go to day services, and then your numbers go up. That's happened elsewhere, and that's not what we want to do. So we have got improvements to make. We're not hiding from the fact that we want to improve, and we're not making excuses. But when you compare with other councils, some councils have got it really nailed on. We want to learn from them, but some councils have got really good figures, but they've just used different approaches in terms of getting their numbers up. So it's just a note of caution about using other councils, all other councils, where their performance is really good. But there are some councils that have absolutely nailed it on. And what they do is they start conversations much earlier. They make it much more of an acceptable process. Richard was speaking to me earlier about the way that we create that. So we make it an easier option for people to choose. We make things straightforward. We don't use domiciliary care, for example, as an easier option than supporting somebody to take up a direct payment. So they're all processes that we do, which is Sarah's point, which is much more, less about direct payments and more about behaviour, culture and practice that we need to push through for our workforce.
And are you prepared to name any councils who are fiddling the figures? Good try. There was a slight smile on his face as he delivered it. But I think it's true what Patrick said, and again shows that you and we are on top of really trying to deal with this, which I express confidence in doing. And to say very correctly, you are correctly saying we're not into fiddling the figures. We're going to have honest debates about these things, be honest where we come up short, and then try and deal with the real problem, not just create something for the sake of it. So thank you for all of that. The recommendations are that we note the performance information. Sorry, Councillor Daunton. Oh yes. Will you still need me when I'm 65?
I'm absolutely happy to. So I think there was two parts to your question. One around the indicators and how they were chosen. So the indicators that we look at have been part of committee's oversight and are part of the strategic framework for the council. So the indicators were taken from that in terms of how we then report. There is a new performance framework recommendation that's going to Strategy and Resources Committee at the end of October, which will mean that we'll be then re-looking at some of the other indicators that we bring to committee to give a more rounded view of the directorate, particularly in light of the fact that we've now got public health and commissioning are all part. So we want to tell the whole story of the directorate and how we bring assurance to committee about what we're doing. So there will be, I think, the opportunity for us to review and have a look at some additional indicators that we may want to bring. In terms of the age differential, the Department of Health and Social Care and our statutory reporting is all broken down into working age adults and then 65 plus. So a lot of the benchmarking and the comparisons against the indicators are all preordained, if you like, in terms of how we have to report from a statutory perspective.
Working age adults, it's not 65 any longer. I mean, I can't remember what it is nationally, but you know, for example, in the University of Cambridge, they did have a fixed retirement age of 67 for a very long time. That's now gone to 70. It's still a fixed retirement age, but it's 70. And in many jobs, there's no retirement age now. So that really needs to reflect what's happening nationally.
I absolutely take your point. Absolutely. Unfortunately, DHSC have yet to catch up with some of that. So, but we'll absolutely feed that back.
And I think it's important to say there's a lot of national monitoring where we're just falling in the basis that all local authorities do in how we organise this and report it. And so some of those issues are outside our control. I think it's important to note that. The recommendation is that we know the performance information and act as necessary. Are people happy with that recommendation? Looking all around, yes, nods everywhere. Thank you very much. Agreed by consensus. We move to item 8, the Public Health Performance Monitoring Report, Val. And sorry, I should say it's pages 111 to 120 of the agenda pack.
Thank you, Chair. The indicators described here are from consider our main indicators from our very much they're mainly statutory services, in fact. And so I'll briefly run through them and pick up on which I think are the most important aspects of them. We've already mentioned drug and alcohol services, and they are obviously fit into achievement of hitting green. A comment on the Tier 2 weight management services being on blue, that is driven by a relentless demand for those services, driven by the recent obesity drugs as well. And that demand, we've had to take a number of measures to manage it, and receive quite a bit of support from partners from both the ICB and the districts to help mitigate that. And then the breastfeeding continues to do well. Picking up on the areas which we are paying more attention to, certainly it's probably misleading in terms of the NHS health checks. Again, one of our key areas in terms of cardiovascular disease and prevention and early intervention. Our numbers were completely shattered by COVID. And it's been a recovery process ever since. And in fact, at the end of last year, we had our highest numbers ever, and it's continued to improve. And I think that's been very much in diversifying the service. We now have a limited number done in GPs, supported by the GP federations, which are groups of GPs effectively that come together to provide a supplementary service. from our behaviour change services, and also through the collaborative work we are doing with the ICB more widely around cardiovascular disease, which has really, I think, contributed to boosting these numbers. It's still amber, but I really hope that we'll meet our stretch target that we put in for this year. Healthy Child Programme, I think we've discussed this before, and I think it's continued to improve. It's certainly better than last year. And I think that reflects a considerable amount of work that's been done, having a new skill mix, and I think of staff, and this has enabled them to be fully staffed. And I think that, again, I think papers have just been going through Children's Committee, and there will be a new section 75 going through next year, which will further develop the initiatives that have already been started. I think part of the low performance reflected the stretch in local target that was included. And in fact, we've always been above, or recently we've always been above the national benchmarking. And I think it's important to have a stretch target, but sometimes it's been very demoralizing to, I think, to staff to see the red against it the whole time. But I think we are continuing to be able to reach that stretch target. So pleased about that. But perhaps our most challenging area is smoking, which is still the one preventative intervention that has the biggest impact on outcomes. I think we've had so much improvement in smoking. Our baseline is sort of rate now, county-wise and nationally, is around 11% of people smoke. But within that, there are groups of people, and no surprise, it's people who are in mental health services, homeless and drug and alcohol services have rates more around 80%. The new funding that's been made available as a result of the smoke-free generation legislation, which is still going through Parliament, but the funding has come down to us already, is really led to us thinking about how can we address those high rates in these groups. There are obviously synergies between the groups. They overlap in many ways. We know that the traditional means of intervention will not work with them. The 28-day quit attempt, it just won't work with this cohort. So the model that we are looking at and developing very closely with colleagues in adult social care mental health services is putting the services inside those services. So it's people who work with the clients, understand them, and will be able to work over longer term to address smoking. And that will be a team that works with people in mental health services, people in homeless services, and people in drug and alcohol services. We're hoping that that will change the number of quitters that we get. We certainly have a challenging national target set with the additional tied to the additional funding. But I think it does show that I think GPs don't see smokers as they did in the past. But we have to get at those groups that have the worst possible health outcomes. And I think it's something we really do need to monitor quite carefully over the next year or so as this new funding comes on stream. And I think the others are sort of picked up in the report, and actions are in place to ensure they don't go from amber to red.
Lots in that. Thank you very much. Who would like to speak? Did I see Councillor Goodliffe wanting to speak? No. Councillor Seif.
Thank you, Chair. Yeah, going on to smoking, my memory is not as sharp as it probably should be, but about a year ago, did we not approve a funding for a very targeted programme of smoking, stop smoking campaign in the Fenlands in particular, which I think it was targeted on that? And I guess my question is, has that special initiative not worked? I mean, we're still significantly below target for many of the reasons, well, all of the reasons that we've just been told, but there was a very specific campaign and we hoped it would be effective.
Thank you. Any other members? Councillor Nessinger.
My questions are all about the health visitor section, so I hope it's okay to ask about that. Well, so the children's section. I think that the figures on health visiting are really interesting. And it's very good to see that they are improving, but they're still not where we would want them to be. I'm going to particularly, I think that while I would clearly love to see the number of visits within the days that they're supposed to be in a better place, in some respects, the figures about the 96% and the 95% are also important. So it's good to have those there. So my first question is the 4 and 5% that we're missing are really important. And do we know whether those are specific groups or are they just kind of slightly random? Because if they are specific groups, that's a crucial piece of information. The second thing I wanted to ask about was the 2 to 2.5 year check, which is below where we would want it to be. I'm wondering whether there is anything in that one which is specific to our area. And I'm particularly thinking about the factors that I became very aware of during COVID about the large number of ghost patients that there are in Cambridge, because people register, stay for a year and then don't unregister. And if we're trying to follow up on toddlers who left the country a year ago, we're not going to make that target. So I just wondered whether that was whether there are particular issues, particularly in Cambridge, because some of those children aren't there anymore. And in which case, if that is the case, I think we need to find a way to reflect that in the target. Thank you.
I really hope no journalists are listening and hear our discussion about ghost patients in the run up to Halloween, because it may not treat that question as seriously as it justifies. Any other members? No, my own comments. First of all, congratulations on the health checks improvement. You know, again, let's not overlook where there's been outstanding progress, and there has been in this. So congratulations on that. It's a really important part of our preventative health approach. It was really difficult post-COVID, and I think it's fantastic the progress that has been made. I think you're right to say that we're not there yet, but that shouldn't mean that we shouldn't acknowledge the huge progress that's been made. And in particular, we've discussed over some time now that GPs are the best place to do this, but they're under such pressure that it doesn't get done, which is a dilemma. So how have we overcome that? We've obviously to some extent overcome that, and let's learn how we did. And although Councillor Van der Ven is not here today, a question that she once asked, and I'll put on her behalf, for the people that are not GPs doing this, that we've got to come in to assist, what have we learned from that? Because this is a different aspect of the service. So what is our learning from in this? And I would join with Councillor Sleeth. This isn't a criticism, but it wasn't just a campaign we agreed a year ago on anti-smoking. We agreed a new strategy, and one that I think, again, we're pretty happy about in all truth. And so what do the latest figures show about whether that strategy is being successful or not? Is it just too early? And, you know, give us some context there in terms of the strategic approach that we did adopt, and I think many of us were very happy with. Thank you. Val.
Right, first question I think from Councillor Sleeth was about the Penland project, and this is our pilot for the work that I've just described and what we have planned. And it was commissioning the Perry project. For those of you who know, it is a long-standing service for the homeless in Penland, and it's been one of the cluster communities projects as well. It's been monitored through that as well. It took a little while getting the grant in process, but we now have staff in place in the Perry project. They are working closely with CPFT as well, because you have that crossover there with mental health services and a lot of their clients. I think it will be a few months before we get any substantive numbers, but we have staff trained, we have sessions running, and I think with this cohort of people, it's not going to happen overnight. It's just these behaviours it's part and parcel of their lifestyle. But we've taken the learning from that and a discussion we've been having with other areas, both in the council and with people who provide the serious mental illness annual health checks. Where we're also putting a resource is that how are we going to engage these people and keep them in the service? And that's what we are learning from the Ferry service and from the ferry project. And I think we probably have that in about, I would say, 4 to 6 months, given that it is quite slow. But the ferry project has been very enterprising in terms of it's also working with its staff, because most of our staff also smoke as well. So it's not going to be a quick process. I think the beauty of, I was saying, of putting it in service that work with our target population is that they see those people on a regular basis, and they have to keep on embedding it into, if they are part of their care, it's no good saying, oh, would you like to be referred to a stop smoking service? It's not going to work. So I think that in answer to your question, yes, I think that we haven't abandoned that program. In fact, it's gone from strength to strength. But I do think, given the cohort, it's a little bit early to say that to get any concrete outcomes. But it is part of this additional funding, so we are being monitored on it nationally as well. So it's we won't be able to escape keeping a very close handle on that. I think the wider strategic approach was very much diversifying how we commission services as well. And I'm going to answer it all in this section, which would, Councillor Howard as well, which was, we know that GPs just don't have the capacity to do it, but the GP feds, which are federations, which are essentially a group of GPs that come together and provide additional primary care services. Effectively, the shareholders are GPs. The same GPs who actually receive those, where the services are carried out, the federation services, and that has proved very effective, because we commission them to do just this smoking work, and it's monitored, and they really have helped to increase some of our numbers. It's a very slow recovery, but they're certainly contributing to it. We've also, in terms of our behaviour change services, asking them to work in a different way as well. They are taking more of the GP numbers off GP practices, and it's more cost effective as well, because it's part of the general contract. So we see more people as at the same cost. And thirdly, it's looking at digital options. And we've been fortunate enough to, and this relates to health checks, to receive national funding for digital versions of health checks, which includes that smoking offer as well. And in fact, we're hoping to put one in here as well for the workers as part of this pilot. It's a national pilot. So we are trying different methods. It's too early, I think, with this particular cohort. Meanwhile, we continue to work with the NHS. They have their own treating tobacco dependency project, which sits in the acute units, mental health inpatient services, and maternity services. I have a particular concern about maternity services, because our smoking at time of delivery rates are higher than anyone else in the region, and it's something that we've asked the ICB to do a deep dive on, which they are doing. But that is another element of the work as well, pregnant smokers. In terms of the acute unit, the advantage is that they do pick up a lot of respiratory services, for example, a lot of smokers, and it's making sure that then they are passed on to our services when they are discharged as well. So it's joining up across the system as well in our strategic approach, instead of a little bit here and a little bit there, and targeting those where we know the smoking rates are. I think the figure I was given this week was 73% for SMI, serious mental illness people in services for serious mental illness and have an annual health check, which was much higher than we expected. It's usually around 40%, so that's nearly double in our services. So there's an awful lot to do in those services, mental health and learning disabilities as well, and drug and alcohol services and homeless. And there are synergies, because you will find people that hit all of those buttons effectively. And then health visiting, I think, was the question around that. I think the feedback I get about that 4 to 5%, that really difficult 4 to 5%, is that it's usually people who you make an appointment and they are not there when health visitors call. So it's usually people perhaps have more say a lifestyle that isn't is less stable than some other people's. And I think that for me, the question is, therefore, how do you make the offer different for people who have these issues? They have a number of pressures, family pressures, children, various services. So the feedback was, oh, sorry, we missed the appointment because I had to go and do another appointment. So how do you get at those people? And it comes back to the question earlier about access, to make access different and provide access in a different way. I think that's a really interesting question about ghost patients. And I think it's well worth looking at, because COVID really did throw up about a high percentage of people that just didn't exist, but they were on practice records and on records. And I think we've had, I think we do have movement in and out of families in and out of the county. So I think that would be something that I'd certainly request people to look at, because we have quite comprehensive child health records, and I don't think they're probably scrutinised as much as general GP registrations.
So the existence of ghosts is proven this morning in this meeting. I think your earlier point about very high numbers of pregnant women smoking at the time of delivery, we're seeing the maternity services in one area of our county this afternoon, so I'm sure we will raise that there. That's a very, very interesting point. The recommendations are to acknowledge the performance and achievements, and B, support the actions undertaken where improvements are necessary. Are people happy to agree that by consensus? I'm seeing nods all around the table. Thank you very much. We now move, Sarah doesn't get time off for good behaviour, I'm afraid. We now move to item 9, the Adults Health and Commissioning Risk Register update, pages 121 to 146. On this one, I'm grateful if you present it fairly briefly, and then we'll just see which questions members have.
Thank you. So the paper provides the overview of the Directorate Risk Register. This now incorporates both adult social care and public health into one risk register, whereas previously we had presented them as two separate papers. You'll see that the risks, triggers and controls are all outlined within the paper, and these are reviewed regularly by the Directorate leadership team. And all risks are currently green or amber, so we've got no current red risks on the register. Happy to take any questions.
This is the point where we really miss Councillor Bowden, who would come in with 5 questions. But anybody else in the committee? Councillor Black.
Yes, thanks, Chair. I'd just like to sort of delve a little bit deeper on a couple of the risks. Risk 6 on page 132, which is providers leaving the market and unable to continue services, leading to insufficient availability. I'm wondering if we've got any of our care homes, domiciliary care services and so on that are causing particular concern now. And also risk 10 on page 140, delivering in budget for commercial services. And I note that particularly notes the problem of inflationary and workforce pressures on our providers and on the market. I would say I'm quite disappointed that we're not at a stage now to be really moving forward on social care, and I think it's a shame that we're looking at yet another report into social care rather than a new government really getting on and implementing its programme. And of course, there's some very obvious things. I mean, looking at risk 10, we've known for a long, long time that social care is underfunded, and I'm disappointed that we're going to be looking at some of the things that are going wrong, and we're going to have to say, well, it's still the government's fault, and it's been the government's fault for a long, long time. But we had hopes that that would be something that would stop being the government's fault. And of course, the other thing that's blindingly obvious and doesn't need a report to tell us is that we must funnel more money into social care without it going straight out the other end into ultimate holding companies in the Cayman Islands or in Jersey, and just increasing the profitability of the private firms who do this work rather than actually getting through to do real good to our service users and indeed the much put upon workforce who work for the private providers. But I mean, I suppose the question is, my feeling is that compared to this time last year, where we had some high profile failures going around, we were getting very bad CQC reports for some of our providers, and we also had sort of providers that did leave the market. I mean, in particular, very high profile care home and a domiciliary care company that threw all its contracts back. So I'm just wondering, are there things on the horizon, or does it feel a little bit quieter now?
I do congratulate you, Councillor Black, for mixing in some very apt questions with some broader comments there, which I asked the committee to have some self-discipline about, because some of what you said, I think, was outside the scope of the risk register. But I think you were elegant in the way that you made your points, so I'm not saying that as a criticism. Councillor Slatter was next, please.
Risk 5 is an interesting one, page 131. Direction of travel remains the same. I think Richard Howard was there. We had a governor's webinar, NHS Trust Governor's webinar, which I'm following up as a Royal Papworth Governor. I'm going to be held responsible for trying to explain the relationships and governance of the ICS to people who are new to that. I know there's a lot of good intentions and a lot of good work. It's going to be interesting to know how you actually are going to assess achievements or change in the direction of travel. It is very dependent, as it says, on relationships and actually people. And so I'm interested to see it there, and I'm glad it is there, but I don't know how on earth you are evaluating it.
And just to explain that, with thanks to Councillor Slatter, this week Councillor Van der Ven and myself attended a webinar of the governors of every health trust in the county. So probably 60 plus people were online, and we were given an hour and a quarter, I think, to really discuss some of the issues around partnerships, relationships, joint working. And I would want to place on record our thanks to the Integrated Care Board for affording us that opportunity, and I hope that that will have been a constructive contribution to improving the relationships in the way Councillor Slatter has just talked about. Councillor Nethsinger.
Thank you. So there are two risks I'd like to ask about, and they're related. And it's possible that the answers will need to come from Patrick rather than Sarah. The first one is the learning disability partnership. Given the work that I've been doing on that with Stephen and the current situation, I'm just wondering whether the likelihood of that risk is still 3 or whether it's actually higher than that. And I wonder whether you would like to give the committee any more update on where we are on that one, because I do think it's quite a serious risk. If you don't want to, I'll obviously quite understand, but I think it is a significant risk for this organisation. I think it's a risk, a reputational risk, as well as a poor outcomes risk, and it's hugely problematic. And related to that is the risk around the governance at the ICS, which again, I would slightly challenge the level of that risk, in that I think that some of the concerns we have about that relationship are quite significant, and I'm not sure whether they're reflected sufficiently here. So I'm mostly giving you an opportunity to talk about that, Patrick. Thank you.
I don't see other members. Just on that last point, I think we haven't got the LDP as a substantive point today. So I think the question from Councillor Nethsinger is, are we taking the risk seriously enough? I'm sure the answer will be yes, but I think it's important that people want to hear your assurance on that. Should we bring you in first on that, Patrick, and then I'll come back to Sarah?
You can do, thank you. So if I kind of go in reverse order and try and address those two. One is around the risk to the learning disability partnership, and just in general terms, as committee know, the committee supported the notice being given to decouple the budget, and there are 3 main areas that remain unresolved, of which will flow from that. Once that clarity on those is found, there will be further work that flows. So the 3 things that remain unresolved are the future integration of the learning disability partnership. So the section 75 is really made up of 2 aspects. One is the pooling of budget between the council and the ICB, and a second element is the management agreement, of which that agrees that CPFT and the council will come together and work as an integrated service. That's been in place for 20 plus years. We've given notice on the pool, and we were very clear and have always been clear that we didn't want to separate the integrated service. The ICB have been different in that view and feel that if we are decoupling the budget, that means that the commissioning responsibilities that formed part of the pool budget sit with them, and therefore they would want to have a greater control and may well want to do things differently about the service that delivers that. So I would expect that in terms of the integrated position, we will get to a formal position probably by the end of this week, such are conversations that progress, and we will give formal notice to CPFT around the decoupling of the integrated learning disability partnership. Our ambition will be that we will continue to work with CPFT around the joint arrangements, but the formal integration, I would expect that that will be a point where we will give notice. So that would be that. The second one is around the packages themselves. So all of the packages are either fully funded social care, fully funded healthcare under the continuing healthcare rules, or a joint funding arrangement. And it's probably the joint funding arrangements where we've got the most challenging, because some of these cases haven't been reviewed for a long time. And as we're reviewing them, they are either all in agreement and they progress either to the benefit or detriment of the council in terms of funding. But there are a significant number of which we have different views to the ICB, and therefore they are in dispute. And there's a risk with those levels of dispute that we get to a point where we need to escalate. The process would be, if we can't resolve it locally, it gets escalated to NHS England. We feel as a team that we're at a point where we will be escalating some cases to NHS England if we can't find a resolution. So we're at that point in terms of those cases. There remains the risk, given the numbers of cases that we're doing and the numbers of cases in dispute, that when we get to the end of March, when the formal notice ends, that we will have packages of care that remain unresolved. So part of our risk assessment is how do we deal with those packages of care at that point. That doesn't mean to say that we aren't focused on the best outcomes for the people who receive this service. And the risk that we've got in here, we will take away as an action to review the risk. But I think the risk in here is very much about the outcomes for people with a learning disability. And our focus is maintaining the best outcomes for those people. This is the internal arrangements between organisations that make sure that that is achieved. But certainly we will go away and review that one. And the final risk around the LDP is the level of debt, and you'll have heard from Justine's presentation around the FMR that we've seen some positive movement on that. There remains some question about some of the historical inflationary amounts that have applied, and some of that is interconnected into the levels of joint funding and the outcomes of some of the joint funding assessments that have taken place. So that's in relation to the LDP as a general point, but in terms of the risk, we will take away as an action to review the risk to make sure that the description of the risk is an appropriate one, because it might be that we want to think about something else which is around the decoupling rather than just outcomes, but we will look at the likelihood of that. On the risk of the ICS, again, it's probably something we want to take away, but it's the terminology. So the ICS is the broader system, and it talks about the outcomes for the population. And if you sit down and look at the health and wellbeing strategy and the integrated care partnership strategy, which talks about best outcome for the population, and if you talk to the council and you talk to the ICB, that we will all say that we want the best outcomes for the population. I think some of the risk to the ICS is the way that we work together as an ICS. So we might want to again review that risk, because it's less about outcomes for population, which probably we would all say we've got our best interests in the population. It's about the detail and it's about the terminology that we've applied to that particular risk and whether we need to review it on that one. On care provision, Councillor Black's right. In terms of care provision, we have strong relationships with our care providers. We keep oversight with the Care Quality Commission and regular connections with them. At the moment, we have a watching brief, but there's nothing that is raising any concern. There is a service that's in Fenland, which has given notice to close, which is a relationship between the landlord and Fenland District Council, but there are people who live in that scheme. It's kind of it's not an extra care, it's a supported living type tenancy. But there are certain people who live in there who have care and support, and we have care packages going in. So we are engaged with the landlord and Fenland District Council around supporting that. But other than that, we have nothing at the moment around care provision. And then budget and commission services. it would be wrong of us to not have that as a risk. I think the risk is right. We continue to manage the risk. A lot of that is driven by our activity and our earlier conversations around the FMR and our financial position. So we actively connect the performance of the directorate against the budget, against the risks that we present, and whether the risks are the right risks, and whether or not they are appropriately risk assessed in terms of likelihood and impact. So that's all of those questions.
That was a very full answer and hasn't given Sarah anything to add, but I'm just giving you a chance if you wanted to add anything.
No, that's fine. Thank you very much, Chair. I think Patrick covered it all.
Leave us something next time, please. Please. On a serious note, on the Learning Disability Partnership, we spoke with Patrick and also with Sally Shaw, and they're going to be briefing us literally in the next weeks by the end of the month on the latest progress on the LDP in detail. But I think you've heard a very detailed answer there to show the level of work and thought that's going into this. On the integrated care system, there's a whole big discussion there that I think you touched on. And Councillor Van der Ven and I believe that there isn't a system in the minute. We're still people too much in silos, and that's what we were addressing in the meeting Councillor Slatter referred to. It's work that we've raised with Councillor Nessinger and the leadership of the council at the highest level, and we should be prepared to be a bit self-critical. Could we do better in terms of systems working as well as our health partners? And so we're thinking about that at the highest level, and I just record that for everyone's benefit. I did see a hand come back, and it was Councillor Seif.
Thank you, Chair. I have a question of fact, and it may be a question for audit and accounts rather than this committee, but I'll put the question to you just the same. I have been made aware, or I am aware, but I don't know the reason why behind it, that private healthcare providers have asked their providers, psychotherapists and psychiatrists, to increase their professional indemnity insurances by a very large amount. And I just wonder how we cover the professional performance of our, first of all, our providers, external providers, and for that matter, our internal social workers and mental health support services, because risk number 4 indicates that the risk is moderate and hasn't moved for some time. And it's a very vulnerable situation, as you actually point out, that you're trying to intervene in a situation where adults make their own decisions. They do some pretty awful things if they have mental health problems. Is it internal insurance or self-insurance, or do we have any sort of professional indemnity insurance, as it were, placed outside the council itself?
That is a risk question, so it's a very good question. I'm looking to see who wants to go first. Sarah? No? Yes?
I'm sorry, I wouldn't know the detail behind that, but we can take that away, or unless Patrick's able to answer.
Patrick?
Yeah, I think we're best to take that away rather than try and give a detailed answer at this
You've
point.
got them, Jeff. Well done.
What I would say is that you were making reference to healthcare services in the start of it, but I accept that there is a lead-on question into our social care services. So we need to make sure that we're satisfied and satisfying and assuring you as committee that we've got a grip on our risk for our own social care services. But there's maybe a question from a scrutiny perspective around how healthcare is managed, particularly with those examples that you gave around indemnity for individuals being told to increase that level of individual indemnity. But we will take away from a social care perspective and look at it from our own internal arrangements.
So Councillor Hay has to share the Eagle Eye of the Day award with Councillor Seif. Well done for that question. The recommendation is to note the updated Adults Health and Commissioning Risk Register, including public health. People happy with that? Yeah, I'm seeing nods around the table. Agree by consensus. We now move to item 10, the committee's agenda plan, training plan and committee appointments. First of all, on the agenda.
No changes to report, Chair.
Okay. The only things I would change, the outstanding item about apologies and accountability, I do want to see that timetabled, and it is very important, as Councillor Black said at the beginning of the meeting, that the charges review comes to December and no later. And as Patrick said, that the terms of reference are properly respected. Anyone else on the agenda plan? Councillor Nessinger.
So I've got a question for the committee chair, if that's permitted, on the agenda plan, which is following up on some comments that you made at the very start of this meeting around items being for decision rather than necessarily for information. I think that committees have slightly different mechanisms of managing this. And I just wondered whether, I think at this committee there's been a certain amount of tension about the agenda in the past. I might be wrong about that. If the committee would want to have more a space on the agenda for items for information, I think it's within your gift to do that. But I think it's something that the committee needs to decide. I don't know whether you want to express views on that now, or whether it's something that you want that the spokes to go away and discuss. But I think it is something that this committee has the power to control.
I regard that as a very helpful intervention, and I would less distinguish it between for decision and for information. And I think you're right to say that probably under our constitution, but it's which information, and it's having strategic and theme-based reports is the one that we've been obstructed from putting on our agenda. I personally think that it doesn't need more discussion, and we've discussed this with Councillor Bowden before, and he's certainly been in agreement when we've made this point as members. So are people happy that we, as Councillor Nessinger asked us to do, that we record that we do want to have these strategic for information reports in future agendas? I'm seeing nods, so I need to look at the Conservatives. Yes. Labour people? Yes, I'm seeing.
Can I make a further comment on that?
Yeah, so first of all, can I just announce that's agreed by consensus all around? Councillor Nessinger?
And I think I think that this is something that every committee needs to kind of manage their agenda in the way that they want to. Just because you've made that decision today doesn't mean it then has to not ever be discussed again. So if there are, if when it comes back again, it's on the agenda plan and people think it's not working well, just raise it again at this point on the agenda and you can revisit it. But I do think that that's something, it is something that is within the power of this committee to control, and you can ask for what you want or say whether it's not working. So I think that's been a useful decision. Thank you.
I think that's a very helpful consequence of the Leader of the Council being a sub here today. Thank you very, very much. So is the agenda plan with the changes that I announced agreed? Yeah, looking to left and right, yes. And then hang on, I need to just get out myself, the training plan. It is under review and will be updated. Are there any specific comments on the training plan? Is that can be noted then, please? Looking for nods. Councillor Daunton.
Just on the training plan, it's just sort of asking for a longer lead-in time between training being announced and the date of the training, if possible.
Very fair comment. Very fair comment. Well, I know Rashenda works very hard on this, but I know that she's listening very carefully. Councillor Slatter, I believe.
Yes, as a chair of the member development plan, and very much in the debt of Rashenda for doing the groundwork. I think it is up. It was discussed at the last panel that we did need to give members, all members, some warning of what was being talked about and an opportunity to contribute the things that they felt they needed, particularly coming to the end of the county council period of government and thinking about the new people who will be coming in and what they need. I'm afraid I have been behindhand in forwarding this to my group for various reasons. I'm not sure whether the Conservative group have had this information, but in a way, I think that the things discussed by the member development panel should be made more generally available. We can always not read emails, but if we don't get them, we can't read them. And it is an opportunity for members to contribute and know who to write to.
Okay, can we just note that at the moment, Rashenda, is that okay? I know you've heard it, and I'm sure it's a very fair comment. I am very anxious to Although note that our officers are quite properly thinking about what will be happening in the new term after the elections and so on, that will be the business of the new council. And so I'm very anxious as a chair to just get on with business now and not let up in any way on what our role is. I am going to close the training plan there unless I see any other members. No, that's noted. And on appointments, our Executive Director, Patrick, in consultation with Spokes, has appointed councillors Taylor and Van der Ven to the North West Anglia NHS Foundation Trust NWAFT liaison group. So thank you to both the councillors who agreed to do that. We also need to formally co-opt the representatives of our City and District Council partners as co-opted members of the Committee for the Health Scrutiny business of them. I don't think any of them are present in the audience yet, so I don't have to ask them to leave the room, which I'm told I should have to do. And they are Councillor Corinne Garvey from South Cambs District Council, Councillor Cameron Holloway from Cambridge City Council, Councillor Keith Horgan from East Cambs District Council, Councillor Dr. Haq Nawaz from Fenland District Council, and Councillor Claire Tevlin from Huntingdonshire District Council. Are all those appointments and notes of delegated appointments agreed by people? Any problems? Yeah. Okay. In which case, 2 minutes early. 2 minutes early. No, Patrick. I was doing so well. Executive Director of Social Care, Health and Commissioning.
I will talk quickly. Apologies. I just won't go back to the earlier point by Councillor Nessinger about the purpose of the committee and the papers we bring. We've had extensive discussions about what papers come to the committee. So I would, if it's possible, would committee support that we take that away to understand and be very clear on the scope of papers that we would bring through that process. Democratic Services will, I'm sure, have a view on what we bring. So I think it's important that we take that away as an action. We'll develop a scope and then get that sign off from committee chair. I'd like that to be noted on the minutes so that we can be clear what we bring back and the work that officers do to bring back those papers for discussion.
As any member of the CLT does, that was extremely loyal to the system and to the organisation. But for the minutes, what I want to get recorded is that the members do not agree with the interpretation as it currently is. It's not satisfactory from our point of view, and that the interpretation has to change. And we've heard the leader of the council say that it is in with our purview to do so. And that's what I want the minutes to say, alongside properly what you said, because you're a loyal member of the CLT and I admire you for it. On that happy basis, no, I think we should stop there. We've got till 2 o'clock when I ask us to adjourn, to re-meet promptly for the health liaison section of the meeting, and I announce on the dot at 1 o'clock that the meeting is adjourned.